You could see a separation, right?
That's a nice healthy split there. You're saying split from the ANS to the PNS, indicative of a full length parallel split along the suture.
That's
Is
correct.
that right?
Yes.
Okay.
I think expansion of the posterior is extremely important. And I think expansion superiorly is very important as well. You could expand the nasal floor like this, or you could kind of expand a little bit like that. A little bit like that, in my opinion, is better than this. So when you do that type of expansion, you don't have to expand so wide and create a huge diastema, and you reduce the risk of dramatic expansion causing asymmetry. That's why all these custom MSE that you see are all anterior, right? They could put screws in the posterior, but it's not doing a whole lot. Oh yeah, he's going to tip his teeth. It's just, I can guarantee you. Look, I don't want to sandbag whoever is doing this, okay? But you're talking about a 30-some-year-old without any sort of release just with this? Give me a break. And even if you're able to do it, and you're going to have your teeth tilted out significantly, even if you're able to split the suture, or you're going to widen your anterior, 1 millimeter, I've seen people call it success. By all means, use this for teenagers. That's more applicable. It's all about case selection, right? And that's what I see with the FME. Oh, geez, the company that you don't need it released. You just do this because we have 3D, lock screws, this and that. Look, the anatomy doesn't change, right? That's why the FME is going to have problems. And I would tell you, I believe the FME is going to have more failures than custom MSEs. Like I said, you're a connoisseur of nasomaxillary expansion. There are a lot that goes into it. Number one, the anatomy. Number two, how it's released. Number three, how it's expanded. What method do you expand? And how you follow the expansion. So, which I spelled out in how I do the operation.
Right.
She came in with her ELF. I said, just take that thing out ASAP, like right now in my office.
Did you call it a thing, or did you call it something else? Yeah. So I have been lacking some sleep. It's like an alarm clock that goes off 6-7 times a night. But I find that it's less stressful than a regular alarm clock that wakes you up for work, because really you're just getting up to see your beautiful little child.
You will subconsciously, you will always be thinking and looking out for her. It's just one of those. It's just one of these things, and it doesn't matter how old they are. My son is full grown, but he's always in the back of my mind.
Wow. So you have one son?
One. That's it.
And how old is he, if you don't mind me asking?
He is going to be 24 next year.
That's amazing. He must be quite a child.
Oh, well, he's our only son, so only kid. So he's a little spoiled, but not too bad.
Well,
you can't help but not spoil your only kid,
Yeah, when you were raising him, did you have considerations of facial structure in mind as he was an infant, or do you not think that there's a big connection between environmental factors as an infant and how facial form ends up developing?
Well, people don't know about this. I actually took his tonsils and adenoids out. I actually got in trouble with the hospital. And he was one of my, really the first full regular ease patient.
Wow.
So, yeah. So a lot of things, and he was actually in one of my early presentations. So everything that I do, if I'm comfortable in doing it on my son, and I know it works, and I want the best procedure for him. He limited my expansion because he didn't want to have a diastema. He was a senior in high school. You know how vanity, how important that is when you're a senior in high school.
Yeah, I do. I do. I've been there. you know, and it's hard for younger people to see the long-term benefit of that. The diastema is just like a temporary sacrifice for long-term happiness.
Well, it wasn't really even a diastema. I would tell you what I typically, I'm a little better now compared to when I first started. But I tell people that diastema is anywhere between 0 to 3 millimeters. 3 millimeter is a very large diastema for me. Um,
Hmm.
the goal is not to create a big diastema, as you know. And so, by the way, I really purposely purposely did not watch any of your videos. Um, I'm here to honestly and bluntly answer and interact whatever you throw at me. I think all my patients will attest to that. I'm very very blunt. There's no political agenda. I tell it as it is.
That's exactly what I'm looking for, doctor. And because you haven't seen any of my videos, you wouldn't know that the history of my channel is me basically making very controversial discoveries in the jaw expansion space, specifically with regards to really deeply criticizing tooth-borne expanders 3 and 4 years ago, before any of the major, how should we say it, more public revelations of the dangers of tooth-borne expanders were made. I was being a contrarian, talking about how dangerous they were, back in 2019 and 2020. So my channel is about truth. It's about journalistic integrity. It's about protecting people, first and foremost, from harmful things. One of my main mottos is you're better to do nothing than to do the wrong thing. So believe me, there's no agenda on my channel either. And all I care about and all my audience cares about is the cold, hard, sober truth.
Well, congratulations. It's that I think that's the bottom line. People, when I see people, when I see patients, at the end of the day, I tell them that you may not be happy with what I'm going to tell you, what I've told you, but you're not here to get happy news. You're here to hear what I have to say, and let's get that out of the way. Tooth-borne expanders. If you're 6, 7, 8 years old or what have you, by all means, do the RPE and all that stuff. But certainly AGA, Vivos, ELF, whatever you want to call these devices, in I would say adolescence beyond. Um, I don't think it does a lot of good. I'm not saying that if your objective is to um, widen your smile a little, and maybe some of those things may be helpful, but I don't think it's the best for your periodontal health um,
Yeah.
with those devices.
Yeah. 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 How do you feel about James Nestor in his book, Breathe, saying that he got some bona fide bone growth in his maxilla from the homeoblock appliance? Do you find
Well,
that there's any credence to that, or is it
well,
negligible bone growth, or what's your reaction to that?
well. At the end of the day, um, something has to make sense, right? It has to make physio. I always say, at the end of the day, what I try to in terms of my practice or whatever treatment there is, one is it needs to make physiologic sense. We know physiology. It has to make sense. That's number one. Number two, hopefully, I have some experience in terms of whether this whatever treatment works or not. And lastly, um, ideally, you will have some scientific data. At the end of the day, anybody could put down, as an old friend used to say, anybody white paper won't reject black ink. What that means is that anybody could write something or publish something, and recently there are a number of publications talking about um, fudge data in science. Estimated 70% of the scientific papers are a bit fudged or categorically false. So I think that uh, as clinicians, that you kind of have to sort of tease through the junk, uh,
Mm-hmm.
so to speak, and you know validate or understand whether one treatment, even though it is quote unquote published, whether that's really good or makes sense. Now, there are some. This will be a question that's really better answered by orthodontists. First, bone growth. Some orthodontists will say, I'm not an orthodontist, first of all. I would tell you that I'm the world's worst orthodontist because I'm not an orthodontist. I'm not talking about teeth movement. Now, if you're going to have tooth-borne appliance, homeoblock or whatever, you're applying pressure on the teeth. Some orthodontists will say, well, they're going to create a little bone growth. Bone growth, is it around the teeth, around the roots, or is it opening up the mid-palatal sutures, affecting the facial sutures? They're complete different things. I know you've been doing this for a while. You've gone through your own treatment experience, so I think you know what I'm talking about. And people like to compare one treatment versus the other or make statements, but it's important for us to have the correct definition of what is bone growth. Okay, where is it occurring? What is the extent of bone growth, and what are the objectives of treatment? Right?
Mm-hmm.
If your goal is to improve your breathing and extrapolate to potentially improve your sleep, I would say that no amount of alveolar bone deposition or increased arch width will have um, any validity in achieving those two objectives.
Mm.
Anybody that would disagree with me, you have to explain to me the physiology behind it and the science behind it. There's so much misinformation, disinformation out there. Um, Unfortunately, a lot of the practitioners is not their. Frankly, we could just talk a little bit about AGA, which is the worst of them all, as you know. I think many of the AGA practitioners, they have no idea what they're doing. Okay, they had no idea. They were told by someone, and many of these treatments, they were told by a company. They were sold a an algorithm or a cookbook, how you could present to the patients, how you could take CT scan, how you could show these things, and then sell these people, your patients, a product that seems like a great treatment that is non-surgical,
Mm.
and that you could achieve the result that that you're looking for. And
Mm-hmm.
we don't have to start naming names, but they are out there, as you know.
Mm-hmm. Mm-hmm. Yeah, without a doubt. Well, I can tell you, I am publishing my ebook called Fix Your Face, The Ultimate Guide to essentially expanders in jaw surgery. And there's a chapter 4 of that book is called How Not to Expand, the Tooth-borne Trap. And it's all about the psychology of how these tooth-borne expanders have sort of taken the market by storm. And I actually get into a deep sort of psychological analysis of why do patients want to believe that these expanders are epigenetic? How do dentists come to believe that by pressing on teeth in adults, you can actually grow bone? What's really going on here? And it's actually really complicated, and it has a lot to do with what I call the honeymoon phase of treatment, which is that for the first year, as these gaps form in patients' mouths, they believe that the maxilla is somehow being extended forward or that it's growing. And the patients then start posting photos saying, wow, my maxilla is growing. And then people see these photos and they believe the story. Oh, it's epigenetic bone growth. We're pressing some bone growth button in the maxilla, and this amazing natural process is happening. In these sort of holistic types, mothers, the same types of mothers who might shop at Whole Foods and buy expensive organic food, they think this is so elegant. Of course, the body has a mechanism for growing bone. And they see these first year photos. And then by the time the patients realize, oh my God, my front teeth are falling out, they're not posting anymore because they're too ashamed. But all their initial photos are still there, and people just keep riding this honeymoon sort of wave of reports, and the cycle just goes on and on and on like that.
Well, I've seen it is interesting in that, yes, I've seen a lot of patients that have had problems and failures and complications. Look, I'm not saying that I don't have problems in my patients at times, but fortunately, they're uncommon. But the failures and the complications that I've seen are horrendous. And you are right. Psychologically, patients are ashamed to tell people what happened to them. So yes, you're absolutely right.
Yeah. Well, there's so many other positive things I want to talk to you about. And if we could maybe loop back around to something you said initially, which is that your EASE procedure, which is your very well-known, extremely highly regarded type of nasomaxillary expansion, you said that 0 to 3 millimeters is the typical diastema that you get. How is it that your expander is only getting up to 3 millimeters of space between the upper front teeth when the maxilla is split, whereas the MSEs and the custom Marpes are getting 7, 8, 9 millimeter diastemas? What's the difference there?
It is very different. At the end of the day, the objectives of all skeletal expanders are the same. I call it nasomaxillary expansion, but really we're expanding the midface. Okay, we're expanding the midface. I think that it will be more efficient for me to just go through a few slides, and then I'm going to go. And there are a number of questions that many people have asked me, and so I think that this is a good opportunity. I thought this is a good opportunity to sort of address those questions. And again, afterwards, I'm happy to answer your questions. So as you can see that I'm not trying to hide anything, right? These are I'm sure many of these questions that you already have in mind. Okay, let's sort of go over some of the questions. Why EASE? Is EASE any better than MSE? Because I think people have said that MSE with the piezo electric saw is all you need. In fact, you could get better expansion. And that one patients have come to have been in say that EASE is more invasive than MMA, as per very prominent East Coast orthodontist. That EASE is a mystery operation, that I'm the only one that does it, and I don't teach anyone how to do it. That I will do not the operation, and you will never hear from me again. That I don't take care of my patients, and that they've heard from someone that had EASE and didn't improve. That the MFE is the new treatment, and that EASE is old and obsolete. And lastly, does Kasey Li want to do EASE on everybody? I'm sure you have more questions, but let me just sort of take this opportunity to try to answer some of these questions. So I'm going to go over some patients. These there's going to be 6 patients that the most recent 6 patients. Okay. In fact, one patient just came in for follow-up this morning on today's Monday, this morning, and he had the surgery on Friday. Okay.
So your point being that you're not cherry picking your best cases from the last 10 years. These are
These
just
are the consecutive 6 patients. And the first patient just came in this morning, and he had the surgery on Friday.
Okay.
So people that my patients know that I operate 2 days a week. Wednesdays in the OR at Stanford, typically, occasionally at a different hospital, but usually at Stanford. Fridays in my surgical suite in my office. So he had the surgery in the surgical suite on Friday, and he came in on Monday. Okay.
Okay. Very excited to see it.
All right. So he's a young man from New Jersey. He contacted me about 9-10 months ago. He had an MMA for nasal obstruction and sleep apnea. Contacted me three months later and said he's not much improved, a little improved, but still symptomatic. And he can't breathe through his nose. And I said, well, I've treated many patients post MMA, and I'm happy to talk about MMA. I've been doing MMAs for 28 years in practice.
I have some MMA questions for you, definitely.
Okay. So you can see that, left is before surgery, right is after surgery. You can see that there's a little bit of swelling. Okay. And you can see that there's a very tiny diastema. Yes. You can see that he's a little swollen.
So just to be clear, doctor, left is before the Is, right is after the Is.
That is correct.
And just for new viewers, can you explain it like you would to a 4th grader? What basically is the Is? What does that involve for the patient? Why is he a little swollen?
Yeah. Is is basically expanding the midface, nasomaxillary expansion. I'm going to go over the operation.
Okay.
So you can see, I've done a lot of MMAs, and I could tell you that this is not MMA. In fact, I would tell you, and I've done a lot of different types of surgeries in my career. This is not a very invasive operation at all. This operation is less invasive than wisdom teeth removal. This operation is surely less invasive than SFOT. I've done SFOT. Okay.
I have too.
Yeah. So you can see that,
how about its invasiveness compared to custom Marpe or MSE with the PIEZO assist?
I would tell you that I've done many MSEs. People that don't know that I've been doing SARPE for 28 years. I stopped doing it. Is surely is a lot less invasive than SARPE. I would say that the Is is, in my opinion, either the same, for sure less painful than 6 or 8 screws of MSE, custom Marpe, and that sort of thing with piezoelectric. Now, people talk about piezoelectric saw like it's some sort of magic. It's just a tool, okay? You could use how invasive something is. It depends. The device and the tool is the same. It's whoever is holding the device. Agree?
Yeah, sure.
So it depends on who's doing the procedure. Okay. So I would just say that. We could go into that a little bit. Yeah. So left is before, right is this morning, Monday, 3 days later. So Monday, so Friday, Saturday, Sunday, Monday, 3 days later. So you can see that there's a very slight swelling at the labial frenum. Yes, can you see that subtle swelling?
Yes.
Okay. I can assure you this is not MMA post-op 3 days. Yes.
Assuredly.
All right. Now, This patient had MMA. So can you see on the right side that there's a separation of the mid-palatal suture?
I can see it.
This is subtle because I expand at the time of the surgery by about 1 millimeter. Can you see a fine line in the mid-palatal suture that goes all the way to the PNS?
I can, and doctor, also, if you want to highlight a feature of an image, you can put your scroller on it, and we can see your scroller, because others might not be as literate with radiographs as I might be.
Okay, so you won't see a black line in the middle of on pre-op. You should be able to see a faint black line. I mean, black line on the post-op. Yes, you can see the device. Yes,
right down the mid-palatal suture, there's a black line indicating space.
Yes, can you see that?
I can see it.
All right, can you see that it's through the PNS? It's subtle. Okay. Another patient, 25-year-old guy from Australia. He has nasal obstruction and etc. He has a bit of a crossbite. He was offered to do a 3-piece maxilla orthodontic surgery straight to MMA. He came to see me, and I said, well, if you really want to improve your nasal breathing, I don't think a multi-piece maxilla is really going to do it. We could talk about that. But so I did the ease. So left is Friday, right is Monday. Okay.
I do want to talk about that, by the way, doctor. Let me know if we can talk about that as part of this, or if we should talk about that after you're done with your slideshow.
Let's talk about the end, because what I'm trying to, if that's okay. So
that's okay.
You can see, right, it's 3 days later. You can see that there's not much diastema. Yes. Not much,
but not much at all.
Okay, but if you can, and can you see that there's a lot of swelling?
Hardly. I mean, to me, if you showed me these pictures randomly, I wouldn't even know really which is the before and after.
The left is always before. The left is before. The right is after. Okay. So look at the overlap of the upper and lower teeth at the premolar and the molar area on the patient's left side, and look at the overlap of the premolar and the molar area on the patient's left side, compare the left and the right. Can you see some subtle width increase of the maxilla?
Yes, I can see
overlap.
Yes, I would.
It's subtle. Okay. It's
less
subtle,
than a millimeter.
I'm sorry?
I would say less than a millimeter.
Yes. But can you see on the right side in terms of the subtle change and overlap?
I can see it.
All right. So, yes? Agree?
Yes.
All right. People, because these patients are blinded in terms of you can't identify them. So people could study them. Okay. So can you look at pre and post? Look, left and right, pre and post. I'm going to talk about pre and post.
Sure.
Can you look at the post-op? Can you see the separation of the mid-palatal suture with the distractor in place?
Yes.
This is subtle that you can't really tell, distinctively that there's the separation of mid-palatal suture from this view. So I present this view. Can you see the separation of mid-palatal suture pre and post?
I see a faint black line in the post photo indicating the separation.
Yes. Okay. And if you look at it closely, you can see the separation anterior to the palatal foramen. I don't know if you can see that. You can blow up.
Can you just explain the anatomy there?
Right, we're looking at basically the ANS, close to the ANS and the from anterior to posterior. So I'm looking at the midline, and you should be able to see that the suture is separated.
Yes.
Small degree, but separated. Yes.
Yes.
Because it's a small degree, but you can see that there are changes in the posterior occlusion.
Mm-hmm.
The width of the maxilla has increased a little between Friday to Monday. Mm-hmm. Yet there's no diastema. Yes?
Correct.
All right. Next patient. 37-year-old guy, sleep apnea over 10 years. And he's from, a lot of my patients are from out of town, out of the country. So he's from Asia, and you could compare Friday to Monday, you could see swelling. Yes. You could see some swelling in the upper lip and the anterior nose. Yes.
Sure.
All right. This is not MMA. Okay. So you can see, again, this is subtle. You could see a little bit of swelling at the, above the, can you see a little bit at the frenum?
Yes. And by the frenum, you mean right here, basically.
Yes.
Yep.
Can you see that?
Yes, I can see it. A little redness and a little swelling.
A little redness. Yes.
Yes.
Okay. And can you see the separation of the mid-palatal suture on a 37-year-old guy?
I can see in the right image a black space in the mid-palatal suture on the right side.
No, is that about 1 millimeter?
Not more than 1 millimeter.
Yes, not more than 1 millimeter. Okay, you could see a separation, right?
That's distinct. That's a nice healthy split there.
To the PNS, yes?
Yes, and when you say to the PNS, you're saying to the posterior nasal spine. Is that what PNS correct. Means? So you're saying split from the ANS, the anterior, to the PNS, the posterior, indicative of a full length parallel split along the suture. Is that right? Okay.
Yes.
That's important because one of the major distinctions to be made between Is potentially and some of the other nasomaxillary expanders like MSE, custom Marpe, you name it, is, and I want to talk about this more later, do some of the other devices expand in a conical fashion where you don't get the expansion at the posterior nasal spine? You're only seeing it at the front, which is important for nasal breathing. We can talk more about that later.
Absolutely. So, the conical expansion was in my paper, my first paper on Is. Okay. Everybody's talking about it. It's like, okay. So anyways.
It's old news to you. Is that what you're saying?
Well, I see that all the time. I'll just say that.
Okay. We're going to talk more about that later if it's okay.
Sure. 33-year-old woman from Georgia. Unfortunately, she has sleep apnea, nasal obstruction. She had the ELF.
Okay. So she has periodontal issues as well?
Yeah. She had the ELF. You could see before on the left, before you could see the molars are all kicked out. Yes?
Yeah. Some molar flaring from the ELF?
Yeah. By the way, on the right is 2 days after surgery when surgical swelling is maximum. Usually I tell patients they're most swollen about 48 hours after surgery.
I've experienced it. And your point again being that Is is not as invasive as MMA, obviously, which is actually a farce to even suggest that. But, we can see that in the image.
I've heard it more than once. I will venture to say that patients look worse than this after custom MSE and piezoelectric saw separation. But so this is 2 days later. Okay, you can see the diastema. Yes, you should be able to see that. Now you can see the posterior maxilla is expanding. Yes.
Yes.
This was her after. She came in with her ELF. I said, just take that thing out ASAP, like right now in my office.
Did you call it a thing or did you call it something else?
Hey, look, I grew up in Los Angeles, and not the best neighborhood. So my patients know, so it's okay.
Okay.
So you could see. We don't have to harp on that, right?
Okay.
All right. So this is 2 days after surgery. You could see the separation. Yes.
Yes.
You could see the separation to the PNS. Yes.
I can see it when I look closely. Obviously,
you
it's a dark image.
Look at it very closely. Okay, but it's through and through ANS to PNS. 61-year-old. She has had problem breathing through her nose forever. Okay. So you can see she's a little more swollen. Swelling is variable between individuals. I would say this is the worst swelling after ease. Okay.
Mm-hmm.
You can see the small diastema. Can you see that the maxilla is a little wider?
I can see it. Yep.
Can you see the separation of the mid-palatal suture?
Yes.
It's hard to see, but you can, you should be able to. I sort of skewed it a little because if you're looking at straight on, a lot of times you're going to be looking at the vomer if you're looking at it straight on. So I sort of kinked it, tilted a little so you could see the separation. Okay.
Yes,
So,
and doctor, just a brief anatomy for the viewers. When you say you're seeing the vomer, you're seeing the bone, which is in the center, the midline. Once you split the suture, there's a bone that sort of lives in the nose. On my skull, it's this, I believe it's this green bone. And so it's like you're peeling the curtains back of one bone and you're seeing another bone there, which is obscuring the split. Is that what you're saying?
yeah, it's not very easy to tell from in some patients.
Got it.
Okay.
Yep.
All right. Well, this is number 6 patient, I think. Now, she's actually in healthcare, and she wanted to share her experience with a group of healthcare providers. So the photo on the right side is immediately after her surgery.
Same day, you mean, or still a few?
It's right after surgery.
Okay.
Left is pre-op, right is 20 minutes after surgery.
Okay.
You could actually, if you look closely, you could see a little bit of swelling, a little bit of maybe a little residual blood stain. Yes?
A little bit.
You look very closely. Okay.
Mm-hmm.
I could tell you MMA patients don't look like that 20 minutes after surgery.
No, they don't. No, they look like the Walking Dead.
Well,
too much.
We won't touch that. Okay. So you could, now this is Monday. Okay. These photos are, the left is Friday or before surgery. Right is 3 days after surgery. You can see the separation. Yes.
And some expansion.
And some expansion. That's correct. You're what I call a connoisseur of expansion, so you can see it.
Sure. That's a first for me, but I'll take it.
Can you see the separation on a 62-year-old? Yes?
Yes.
Can you see the PNS separation on a 62-year-old?
Very nicely on this image.
Okay. That's not the oldest patient. 68-year-old. I presented this patient in my French lecture. So the reason I wanted to go over it. At the end of the day, I want to maximize the expansion. We're going to talk a lot about this. So this patient was actually recommended to have MMA.
Okay.
Okay. And she came to me for second opinion. So I asked her, what are your objectives? Okay. What are you trying to achieve? Do you mind using CPAP? Because she was on CPAP. She said, I just want to treat my sleep apnea. I don't want to have risks that are associated with sleep apnea.
Mm-hmm.
I said, well, do you mind using CPAP? No, I have no problem with CPAP. I said, well, yeah, you have smaller jaw, but and she had problem breathing through her nose. I said, well, 62-year post-menopausal woman, do you want a fairly big operation? Or, I think that it's very reasonable for you to consider ease. So I did the operation for her. She had a small jaw. And I completed expansion on the left side. The device ran out of space. She was still improving. Okay. Can you see that? This is a typical ease expansion. Okay. you could see that there's a small amount of what I call inverted triangle.
Mm-hmm.
Okay, because she got basically mostly nasal expansion, yes?
Mm-hmm.
But she was still improving. I said, well, if you are still improving, I could reposition the device and we keep on going because you are still improving symptomatically. So I repositioned the device under local anesthesia and we kept on expanding.
Did you
Okay,
have to reposition it because you can't use the same holes? So you took the device out, you reset it, and then you put it in a new place where there was fresh bone?
exactly.
Okay.
Okay. So we expanded until she's, not really getting any more improvement. And we could actually touch on that. I said it repeatedly in my prior lectures that I am not trying to achieve an intermolar distance of X. There is absolutely no evidence, and I know there will never be any evidence demonstrating normal intermolar distance or large intermolar distance will give you that patients will have good nasal breathing.
Mm-hmm.
There's it gives me it basically it reminds me of and when I was younger. Still today, I see patients where when they have MMA and they were advanced 4 millimeters for their sleep apnea because the cephalometric, or whatever. It's kind of like trying to normalize cephalometric measurement. It's the same thing. They're not thinking about physiology. They're thinking about, oh, what was I taught in dental school that the intermolar distance should be X. Do you know where those where those dental measurements came from?
I don't.
Well, they came from studying some skulls of different people or studying some x-rays and what is average. This is not, we're talking about medicine, right? I mean, we're not talking about straightening teeth. This just, it just sounded so, well, I don't know.
Arbitrary. It's arbitrary.
It's arbitrary, right? When I treat patients, why do patients come in to see me? That's very important, right? Are they trying to have a
Symptoms.
better smile? Are they trying to improve their breathing? So if their goal is to improve breathing and sleep, I want to expand as much as I can to improve their symptoms. And I try to go beyond it to capture any sort of residual improvement because patients will hit a plateau. Further expansion does not yield further improvement, then I don't keep on going unless some patients say, I like a little wider smile, and we could touch on that, okay? But it's almost like a drug, and I don't have to tell you, these people just want to keep on going, and I have to put us. And by the way, some people, I think, when people say, "Oh, I have some external change," look, you're going to have a little bit of wider cheekbones, and I think you know that, okay?
Mm-hmm.
Because this is a midface expansion. But noticeable nasal changes or whatever, that is from. I've had number of patients when I say it's time to stop, and you know what the answer is?
I want to keep going.
I want to keep going.
Yeah.
So so I would say, you know what? You need to stop. When they want to keep on going and they have some external changes or whatever, there's nothing I can do about it, right? At the end of the day, if they want to be treated properly, they have to follow my recommendation. Sometimes people have to take responsibility. So I don't appreciate it when people say, I have external changes or unfavorable. Well, it's not on me. Make
Mm-hmm.
sense?
Yeah, it makes sense. Can we dive a little bit deeper into that? Do
Yes,
you think that when it comes to nasomaxillary expansion, the benefit to expansion ratio is not linear,
it is
which is
not
this?
linear.
Okay.
No. People say, well, this Lee guy, I can tell you, vast majority of patients vast majority of patients, they notice improved nasal breathing that day, surgical day. When they wake up from sedation, they know it because they go from 0 to 1 millimeter. And, I try to show people the geometry or whatever. 1 millimeter is not a small deal in ease. Okay.
Yeah.
So, but sometimes, uncommon, but sometimes people will say, well, I didn't really notice difference, but usually there's improvement, within a few weeks. There's a woman said, after a couple months, I started noticing improvement. But so now we could get to talk a little bit about success rate. I tell every patient, the probability for your nasal breathing to improve is 95% or better. That is my data of 300, between 300, I've not hit 400 yet, but 300, we could say 350. The probability is very high.
350 ease cases, is that roughly how many you've done?
We're going to say 350, somewhere around there.
Okay,
I mean,
sure.
I'm not including teenagers or kids. Okay, kids, I mean, we could talk about kids, but today's really, I think about, adults.
Indeed.
And most of them, 80% of them, they experience improvement of sleep. The data is out there. Okay, we could talk about the data a little bit, and I published it. So let's just move on because I'm almost done with the slides. Okay.
Okay. Sure.
So by the way, do I charge the patient? No. This is not when I treat patients, I want to take them from the beginning to the end so that, at the end of the day, I want to help patients. But at the end of the day, I have a certain standard. If I feel like I could improve this patient further, I will do what's needed. And about 10% of the patients will have more than one sort of switch, and sometimes two. Mm-hmm. Okay, because certain problem or whatever, I want to try to get as much as I can for the patient. Does that make sense?
It does.
All right. So, you could tell that there's a. Can you see on a 62-year-old? Is there any sort of alveolar bending?
There doesn't appear to be.
No.
The teeth still all appear to be lingually tipped.
Yep. Okay. So this is before and after. Okay. You can see left is pre-surgery, right is in the middle is at the end of the first device. On the right, far right is the end of the second device. Mm-hmm. Okay. You can see on a 68-year-old, she's my oldest patient. So you can see that it's a through and through ANS, PNS. Yes?
It's a beautiful split.
So I tell every patient, if they're on CPAP, practically everyone will have to adjust their CPAP because, people don't know. I've dealt with CPAP or work on CPAP, but don't come to me for CPAP, please. Okay. In that we used to play with OPAP. You know what OPAPs are?
I don't.
Instead of air through the nose, it's air through the mouth. It's a mask through the mouth. Mm-hmm. Okay. The CPAP pressure basically is half of what the nasal CPAP is.
What do you mean by that? You're saying after ease, it's the pressure drops?
I'm just talking about OPAP.
Okay, OPAP.
If you use CPAP through the nose and CPAP only through the mouth, your pressure is going to be a lot. Let's say CPAP pressure is 10 centimeters of water. Okay. Mm-hmm. Your OPAP pressure is going to be 5 or 6.
Okay. Because the mouth is a bigger tube.
Well, also because the nasal space is the nasal resistance. It's you have to pump the air through the nose. Mm-hmm. Okay. So when patients that are on CPAP, when they go through ease, I tell them you're going to need during the ease, you're going to need to drop your CPAP pressure. The range is typically anywhere between 2 to 5 centimeters of water. Mm-hmm. That's because the nasal airways is expanded. Yes?
Yes.
Okay. So her nasal airway was expanded. So she dropped to, I don't know what it is, down to from 7 to 11 down to 4 to 5. Okay. Now, I blanked out everything, but you can see the far left is her pre-treatment, pre-ease sleep study. You can look at the 4% drop and the 3% drop. Okay. You can read that. Yes.
Patients who might want to get more into detail on this slide can pause the video and
you can watch
zoom in
and you
read
can look
it.
at the pre-surgery RDI and HI, 3% and 4%. The middle is you can see, you know, the 3%, 4% HI. So you can see that there was an improvement. Yes. And on the right side, I want to be straight up. So you can see that the interpretation is that the patient has significant improvement after ease. Yes?
Yes.
This is another patient. You know, this is probably the most dramatic. Significant reduction in the RDI. Yes? Left is pre, right is post. You can see that the top is basically discussing that significant improvement with the same methodology. Yes? Okay, so I would tell you that there is more data in terms of what the ease does compared to MSE, compared to Marpe, compared to any other expansion method other than the RPE in children.
Fair enough.
Okay, if people want to talk about Marpe and PIEZO and whatever, they have to present data. All the data is from, you know, whatever meta-analysis from a couple of cases here and there or whatever. There's no studies.
Yeah.
Okay. There are no studies.
Why is that?
You know.
No, really. It's a sincere question. Is it because the data is too scattered across many providers?
No.
Because they're not going to like what they find in the data?
You know, I've been practicing for a long time. I've done a lot of things, right? You could look in my background, okay? You know, a few years ago, I was actually thinking of retiring. Okay.
You would have missed out on a lot of action if you did.
Well, I would tell you, I couldn't retire. I couldn't retire because of that. I was seeing so many complications from MMAs, so many complications that I've never seen in the first 70-80%, the first 20 years of my practice. They're just coming in like these horrendous complications, number one. And number two, the sleep field has gone through a significant change. There's so much junk that's being propagated.
Yeah.
And I just couldn't walk away from a field that has really rewarded me intellectually. You know, so that's when I developed the ease.
Wow.
I've been doing SARPE, like I said, for many, many years. And it's, you know, there's a reason. Look, I could easily just continue to do SARPE, continue to, you know, modify or whatever. But, you know, so to answer your question, you know, I think you know all the people that do the other type of expansions that I do, right? They're in private practice, right?
Okay, sure.
Okay.
Sure.
You know, I have been practicing for a long time, but I want to stimulate my brain. I have a certain interest. I want to. I mean, look, I'm not saying neither and there. I try to publish. I try to develop because I think that it's, people will say, well, gosh, you don't specialize in orthodontic surgery. Well, uh, excuse me, I'm able to do a lot of things. I want to do a lot of things because, otherwise it's kind of monotonous. You follow
Hmm.
me?
Yeah.
I have 10 plus patents. I mean, things that it's not just about practicing. I want to take care of patients. I want to improve them. That's what keeps me going. Is the reward that I get from my patients. It's but so yeah. So when people start telling me that I'm the only one that does it. Yes, I'm the only one that does it. Um, and that what I'm doing has no validity. Um, I show the validity. I show the expansion works. More importantly, it's not the expansion. It's what are we doing for them? Is to improve their symptoms. So you could, I just basically these are anecdotal, but I show you the pre and post, right? And
Sure.
it's been published. So I would pose the questions. Please show me the MSE custom MSE piezoelectric data. Not much.
There's a lot of anecdotal data of people by the way, including myself, who did an MSE back in 2019. I got a tremendous amount of nasal breathing improvement
Yes,
from it.
absolutely.
Um,
I'm not saying that MSE doesn't help patients, but when I'm addressing the questions to me that
yes,
Ease has no data. Well, Ease has data. In fact, more data
more
than
data.
MSE.
Sure.
Okay, let me finish up if I may.
Please do.
All right, so we're going to talk about the Ease operation. Okay, I developed the Ease and then published it and presented, I think, in 2018 and published in 2019. Why? It's been quite a few years, yes?
Yes.
Why? How come nobody else does it?
Um, they're not as experienced as you. Is that what you're suggesting?
You know,
So let's just be clear about the X and Y axis here. So on the X, on the Y, we have different types of providers, and on the Y
that
axis we
does
have,
MSEs. That I assume would do expansions.
okay, types of
Okay.
doctors who do expanders, nasomaxillary expanders on the Y, and on the X axis we have years of training and experience.
Yes. I can't tell you how many years of experience that other people have.
Right.
I can tell you that I've done a lot of different types of surgeries. Now, you know, I went through a residency in ENT. I went through a residency in oral maxillofacial surgery. I did a fellowship in facial plastic surgery. Now, I'm not saying that I'm better, but I'm saying that I've done more in terms of been exposed to more. And that I'm not just sitting on my rear end eating bonbons and watching TV at home. Yes,
But
I hope.
doctor, I thought you were a TMJ general dentist.
uh, yeah. All right. So, and if you could see that throughout my practice, I've been doing orthodontic surgery since day one. I've been doing SARPE since day one. And the
Doctor, when you
X,
say forgive me, when you say SARPE, do you mean dome cuts with the tooth-borne expander? What do you mean when you say SARPE?
SARPE, well, SARPE is basically Hyrex device, Tooth-borne, mid-palatal cut, Lefort cut.
Okay.
That's SARPE. By the way, people talk about dome. The dome is basically adding a few screws, right? We agree on that?
The dome is adding a few screws. When I think of dome, I think of dome exclusively as a kind of surgical assist that includes mid-palatal cut and Lefort cuts.
With an MSE.
With a skeletal expander.
Right.
Right.
Well, we don't have to talk about dome because that's not the topic. So basically it's a SARPE. It's a form of, it's similar, very, very much the same, right?
Except
So,
bone-borne, except bone-borne instead of tooth-borne expander.
yeah, it's a hybrid. It's bone-borne and tooth-borne, right? With the dome. The SARPE is tooth-borne. How the expansion works, we'll talk about dome and SARPE. How the expansion works depends on the cut. At the end of the day, everyone harps about the, expander design or what have you. It depends on how the procedure is done, and how the expansion is going to work depends on how the procedure is done. I've shown a lot of cases of dome. When people do an operation, it's not just doing an operation. You have to think about what are the objectives of the operation. Look, I was never a fan of SARPE. Okay. I've done them. I published them. I published them in 2001 for the treatment of sleep apnea. And I will venture to say, when I was trying to do expansion to help patients, to improve patients, many of the MSE experts are still taking teeth out and putting in heck years 20 years ago.
Mm-hmm.
Okay. So,
right.
I don't think we need to talk about SARPE. To me, SARPE is just not a very good procedure. So what
SARPE,
I'm saying,
on my channel, SARPE is old news. Dome is old news. Those are way past. We're way past that.
So what I'm saying is that I've been exposed to a lot of different procedures and knowledge and all this stuff, right? And so in order to do ease, by the way, it's still endoscopically assisted, okay?
So there's rumors that I've even heard people say to me, I heard Kasey Li is just using PIEZO cuts now and cutting the nasal spine and the mid-palatal suture. It's not even endoscope assisted anymore. Is that false or true or
Well,
what?
there are a lot of things people say, right? I use an endoscope on every case, okay? And well, you could tell me, you see these patients, I show the consecutive 6 most recent patients, okay?
Mm-hmm.
Do they look like piezo cuts? Have you seen them?
I don't know exactly what a piezo cut looks like on a scan, so it's hard for me to say. But what I will say is that all of your images demonstrated ANS to PNS parallel split, which it's being said, and one thing I want to talk to you about, cannot be achieved with a custom Marpe and a piezo. Although Mariana Evans did come on my channel and present that her custom Marpes do achieve parallel ANS to PNS splits.
What,
So,
on the 21-year-old? I'm showing you case. I'm showing you
68-year-olds.
I'm showing, and you don't have to just watch. I'm basically showing you this, and 61, 62, 60. So I'm showing you, and if you could watch my lectures, there must be 100 cases in these lectures. By the way, I don't use the same slides. I don't use the same patients. These are not canned talks. Okay. When I give a lecture, I want people to understand that, I take it seriously. This is not just, and as you can see, I prepare for your interview because this is not, I want to present knowledge and facts. And because there's just so much out there, right? So,
Yeah.
So what the slide basically I'm trying to say is that in order to do ease the way that I do it, there's skills that oral surgeons don't have. There's skills that ENTs don't have. and there's skills that orthodontists don't have. That's how I was able to develop this operation. We call it operation, this procedure, because it's from all the different experience and knowledge and things that I've learned and developed over the years. I hope that makes sense. By the way, so that's why I asked. I developed this and published this since 2018, 2019. Why is it that other people are not doing it? Well, let me just tell you, I've seen many complications from ease that I've heard and that came to see me. Okay.
What do you mean? Other people doing ease?
Yes.
Yeah.
Yes.
And when you say other people doing ease, are they just calling it ease, or are they actually
Well,
doing?
there are people that call it the ease, and there are people that try to do the ease. Okay.
The endoscope assisted ease, the real ease.
Well, let me just say that I've seen patients where they have bilateral nasal synechia, basically scarring of the nose on both sides following ease attempt.
Trying to do the unique endoscope assisted release.
Yes.
They're not doing it the way that you do it.
That's correct.
So can you indulge us, doctor? What's different about the way you do it? And this gets back to your initial slide, that there's an air of mystery around ease. And there's a lot of people who are...
Sure. Well, can we go back to that slide?
To slide number 1?
No, the slide that I...
Yes.
Okay. So there's no mystery behind it. It's, I didn't invent it, but you don't know what you don't know, right? If you've never been exposed to it, of course you think it's just mumbo jumbo, mystery or what have you, right? Okay. This is the ease operation. My first ease, or my first, first few, was 2 hours. Okay. I hope that that if you do something a lot, you'd be better at it. So it takes me about 45 to 60 minutes under endoscopic guidance. Now, it's either sedation or general anesthesia, depending on the setting. You could actually do this procedure under local anesthesia, but something in the nose for, with the scope is not the most comfortable, okay?
Of course.
So it takes me 45 to 60 minutes. Now, you could see from those patients, at the end of the operation, they are expanded, okay? The sutures are separated. This is a misconception. The expansion of the nasomaxillary complex is what I call force transfer. I am exerting force on the palatal bone so that the force will transfer superiorly to affect the facial sutures. This makes sense? That's that's the objective. So I do not want, there's no guessing game, okay? I do not want to waste the force on trying to split the suture. Okay? So the surgery takes me 45 to 60 minutes. It's expanded at the end, okay? I expand. Now, people will say, why does it take so long? Okay? Again, it is all about force transfer, and each time I'm turning, the expansions. Look, I'm affecting adult skulls, yes? Okay, I'm not affecting a pediatric skull that's 10 years old. By the way, I've done many skeletal expansion, nasomaxillary expansion on the pediatric population. Now I do exclusively bone-borne MSE. It's
What's your youngest skeletal expander patient?
I think 10.
What do you do for like a 4, 5, 6-year-old that's having poor?
RPE.
Okay, that's a tooth-borne expander.
Right. Okay. But you're going to see alveolar tipping in RPE. Okay. And
why use RPE on a pediatric patient under 10, but not a skeletal expander?
Well, you know, and look, there's a little difference between putting in 4 screws on a 6-year-old versus a 10, 11-year-old. You know, I mean, it's a little invasive.
It's traumatic for the child.
It's traumatic.
Yeah.
Okay.
No doubt.
So we'll get back to the operation.
Yes.
You happy so far?
Yes, very happy, doctor. Very grateful for your time.
Blunt enough?
Well, you've actually been pretty careful and chosen your words pretty diplomatically.
Well, I am a surgeon, right? And I'll just say that I've been presenting, I don't know, hundreds of times all over the world, and I don't know if you the famous phrase Henry Kissinger, by the way, recently passed, has always been credited with the saying, "Why do people in academic fight so hard, fight so nasty?" Because the stakes are so small. Okay, so
right.
Look, I've swam with the sharks. Okay, so I'm more than happy to have an academic discussion, because at the end of the day, it's not who could yell louder. It's what facts or logic can you bring to the discussion. Okay, and look, I know I'm not well liked. Okay,
you're well liked on my channel.
Well, we could just say people that are proponent of the custom MSE, because I know I've seen many of their patients, and they obviously are dissuaded to have me do EASE or MMA, but it's neither here nor there. At the end of the day, whether patients come to me for treatment or for opinions, I'm there to provide accurate information. So let's get back to the surgery, okay? So it takes a long time because it's a pure skeletal expansion, and I'm affecting the facial sutures. So it's very small and incremental.
So doctor, what tool do you use inside of the nose that's able to so you cut down? Is that right?
I am not cutting in the nose anymore. I'm using a scope to guide, to make sure that I don't puncture.
That you don't puncture into the nose?
Yes.
But you're cutting in the mouth?
Correct.
With a PIEZO knife?
With the small with the PIEZO or small osteotomes or whatever. I mean, depending on the patient.
It's just a saw. A saw is a saw.
The PIEZO electro, yeah, small saw, or just like the orthodontist, just look, I don't have any magical tool. Okay, so
why do you need to watch inside of the nose to get
deeper?
If
you cut through it, then you're going to have oral nasal communication. That's I've seen that. There's one case. So that's not what you want. You want to prevent complications, right?
So you want to go as far as you can go without going too far and cutting the soft tissue at the bottom of the nose, which causes literally food to go into the nose or mucus to come down into the mouth.
And your PIEZO electrode saw, it affects healing because it's heat.
It gets hot.
It's heat.
Necrosis.
Right. Okay. And if you're going to necrose bone, just imagine what your mucosa is going to be like.
Permanently damaged.
So it's a delicate operation. Okay.
So
And let me just say this.
mm-hmm.
Let's get back to the slides. Let me just say this. The skill of operating with the endoscope. Can we go back to I'm going to go back to the previous slide.
Yes.
You know, FES, when I was an ENT residency, I learned about operating with a scope. Okay, when we do sinus surgery, it's all scope, right? I did a fair amount of endoscopic sinus surgery early on in my career. Okay, it's a skill. It's a skill that you have to manipulate both hands. Does that make sense?
Yeah, I can imagine a knife in one hand and a scope in the other hand.
Yeah,
and there's a lot of moving parts there.
Yeah, it's a skill of an otolaryngologist, not an oral maxillofacial surgeon, and not a sleep dentist, not a TMJ specialist, not an orthodontist that specializes in MSE. They've never held a scope before.
Not a TMJ general dentist?
You know, Ron, I'm starting to like you.
That's good. That's
okay.
Good.
So, and other than an ENT, other than an otolaryngologist, people don't have scopes in their office. Yeah. Okay. And you'll say, well, some ENT can do it. The skill of managing bone. Look, I'm just trying to tell people my perspective. I'm not here to insult or throw rocks or whatever, other than TMJ dentist.
That's totally fair game.
So I'm a board certified otolaryngologist. Okay. So if you want to deal with bone, oral surgeons are better with bone. I'm also an oral maxillofacial surgeon. Okay. So I went through both training. So I know what the training, everybody's training is like. Okay. So to deal with the distractors and all this stuff and all that, it's not really in the skill set of an otolaryngologist, ENT. Okay. Now, I haven't gotten to other important factors. Okay. We'll get back to the slides. So
yes, go ahead, doctor. I have so many questions coming to mind, but I'm going to just bite my tongue and
Ron,
let you continue.
I'm all yours.
Thank you.
Okay. So
if I could just briefly, doctor, here is a sample of PIEZO cut having been done on a clay mold. Okay. So you see a cut down the middle here.
I don't really see it, but okay, I take your word for it. That's okay.
Okay. Here, I will do this. You see a cut down the middle here.
Well,
you see
it's small, but let's see. Yeah.
Cut down the midline here.
Yep.
Actually, it's not a continuous cut. It's dipping in and out of the bone.
Okay.
To prevent necrosis.
Okay.
And to keep the cutting line wet to prevent necrosis, to keep the heat down. Just like a tiler, when he cuts tile, he uses a wet saw to prevent it from overheating.
Yeah.
Okay. Now, what you're saying is that what really makes Is special is that with the endoscope inside of the nose, you are able to be more aggressive than the PIEZO cut because you have eyes on the inside. You can get a more full release because you're not blind, which the PIEZO cutting orthodontist cannot get because he has to be careful not to go too deep. He has to dip in and out only. He can go, but he can't go too far because he's blind. So what the Is allows you to do is to get a more thorough release that ultimately leads to better, cleaner expansion. The appliance,
That's just a part of it. That's just a
it's just a
small part
part,
of it.
but it's an important part because with ease, the appliance does no work in splitting the suture. The appliance purely expands the operation fully releases the suture.
I am not I would rephrase the word of more aggressive cut. Okay. Um, I am I am I would say that the in my hands. Now, do you think that the 6 patients that I showed you, did they have aggressive operations?
No,
Were they beating
maybe
the crap out? Did I beat the crap out of them?
no.
You know.
They're 60-year-old women. I hope not.
So it's. Let me finish the operation and we could
Okay.
discuss. Okay.
Okay. Mm-hmm.
So we agree that at the end of the surgery, patients are expanded, sutures are open. Okay. Now, I am using so when you have something, so we're jumping the gun, but I think this is a crucial point. Okay. Look, every device has inherent problems. Okay. But a device that attaches the palatal bone is an inherently flawed device. Okay. It's inherently flawed to achieve nasomaxillary expansion. Number one, you've seen plenty of CT scans, and like I said, you're a connoisseur of nasomaxillary expansion. In vast majority of patients, the palatal bone starts to thin out significantly around the first molar to the PNS. Agreed?
The bone gets thinner the farther back you go.
Yes.
Yes.
And most of the time, it's quite thin. So I don't care if you're putting 12 screws in there. The screws that are working are sort of anterior to the first molar. That's why all these custom MSE that you see are all anterior, right? They could put screws in the posterior, which I will show, but it's not doing a whole lot. Okay, that's number one. Number two, it's the operation, right? So when I'm doing the surgery, I'm making sure that, there's no problems. I do it very delicately. I will venture to say I'm pretty good with saw or surgical instruments, having been doing it for many, many, many years. Yes.
Yes.
Okay. So if you want me to, look, I work with orthodontists all over the world. We're colleagues, but we're talking about specifically MSE specialists where, many orthodontists don't believe in nasomaxillary expansion. Okay. Or look, I think MSE is great. I think it's great. And I do it myself. Look, I before Ease, I was using acrylic tabs. Look, I've been there, done that. I've done them all. Okay. So when you are placing the MSE, it's just like the FME. Just like the FME. Okay. I know that that the placement is different, that they're 3D guided, and they're going to put 6 screws and blah 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 and all that. Look, I hope that FME is successful, because ideally you want better treatment. Okay.
Of course.
You want better expansion, but it's not the device design. It is the anatomy. It's the anatomy, and it's how you do the operation. Mm-hmm. Okay. Just because you poke a few holes is not going to be, it's and so when I do the ease, sometimes there are times I would take the device, take the TBD device in and out and see how the expansion works, and I may find out where it's sort of sticking, and I would alleviate it. You can't do that with the MSE. It's screwed on.
Right.
Right? There's so, and I could go on and on about, I'm a connoisseur of nasal maxilla expansion, by the way. Okay.
A real connoisseur.
No, it's just that I've done a lot. Not that I'm smarter. I've just, look, at the end of the day, I've done a lot and I've learned a lot, and I know what I'm trying to do, and try to think about, look, my assistant would say, you've changed your way of doing it again. I say, yes, because I want to make it less invasive, more predictable. So, okay, so we haven't gotten to the other important aspect. So let's so you see how different how different it is.
Yeah, what I'm really getting from you is that ease is not a commoditizable thing that you can just put on the shelf somewhere and order from Great
No.
Lakes. It's really integral to the whole ease process is your peculiar surgical skill and experience. It's
how the bone feels. Look, I view surgery as an art. It's not about, I'm going to do, VSP, I'm going to design this, and anybody could do that. Surgery is an art, at least in my hands, okay, in my opinion. How the bone feels, how it sounds, it's real tactile to me, okay? And look, I've been doing this for a long time. So it's and the way that I do the expansion, and by the way, if you ask any mechanical engineer, okay, doing this versus doing this is very different.
Right. The fact that the TADs of the MSEs and the custom Marpes generally
And the
are
FMEs
and the FME are perpendicular to the bone. And so naturally there's going to be a tendency to have sort of, well, actually more like this.
Well,
the TADs are going to
you can your force exertion is a lot less efficient when you're doing right angle versus just sort of pushing out. You see the guys that are climbing two parallel walls, these Jackie Chan or whatever. Okay.
Sure.
I like to see Jackie Chan doing this with the two sticks and doing it this way. He won't be able to do it. It's the force exertion, right? Okay. And I'm sometimes I take it in and out and reposition it and see how the device is working. And so it's an operation. It's an art. It's not selling a Big Mac. Okay.
Exactly.
All right. Let's get back to the operation.
Okay.
So I want to make sure that the expansion is going well. So all my patients stayed 2 weeks. When they're international patients, I wanted to stay just a little bit longer if possible. Okay. And the amount of expansion, the degree of expansion is variable between individuals because it depends on how stiff their midface sutures, how stiff their skull is. Does that make sense?
Yes.
Okay. It's not one size fits all. It's never one size fits all. Okay. So and then I teach them how to do it. By the way, when patients are in town, they live close, they want to come, like those two Palo Alto patients that one of them can do it herself. So she sends, so every patient, so I expand 3 days a week. Okay. 3 days a week. And every time they expand, they send me 3 photos. 4 months. Okay. On my phone. 3 photos every time that they expand. Anybody, if any of my patients that I've treated, can freely, whatever, voice their opinion. If people think that people could say that I'm telling giving false information, because I'm very compulsive. Why do I do that? And I would tell you, 3 to 6 months, 6 to 9 months, sometimes longer in men, in middle-aged men, okay, 40, 50-year-olds, could be longer. So why do I do that?
Mm-hmm.
Well, because I want to make sure that the expansion is going well. Okay.
Mm-hmm.
Now, why do people have problems with MSE or with Marpe? And I see some horrendous asymmetries. I'm sure you've seen it too, right?
I've seen it a lot.
Yeah. Why is that?
Well, my understanding is that it could be because of poor appliance design. It could be because of poor appliance placement. It could be because of not sort of rolling with pre-existing asymmetries in the patient's face.
Well, there are a lot of problems, right? I've seen some horrendous that it's not fixable.
I
Okay.
have as well.
Yeah. So, but
What's your understanding? What you tell me? Why do those asymmetries happen in MSC and Marpe patients?
well, there's so many variables, but one important variable is that you got to follow the patient.
Yeah.
Okay. I there's people will people would start turning for I don't know how many times before they come back for follow up.
Yeah.
Yes.
Yes, absolutely.
Okay. So if you don't believe it, I can show you my phone. I manage patients. Look, if they are my patients, if they're my patients, they have all of me. Meaning that I want to make sure that it's done right.
They have your cell phone number, is that right?
They got my cell phone number, yes, and they send me photos 3 days. And sometimes a lot of times I say, you know what, 25% less. You're turning too much. This and that. Look, I know every patient. Okay, so
Mm-hmm.
because at the end of the day, I want to make sure that the result is good. You tell me another surgeon who's going to get 3 photos 3 days a week from 30, 40 patients for months or throughout when they practice.
Unheard of.
Okay, so now and if something's not right, I feel like, okay, you know what, I want to reposition it. I tell them, I want to reposition it. And why do people do it? You know why people do it? Because they are improving. I want to maximize their improvement. Okay,
Mm-hmm.
so look, when look in my mind, when I take care of patients, we're on the same team. We're in the same boat. Okay, something doesn't go right. It we have to work together.
Yeah.
So now you know why, and I have certain standard. If I feel, look, by the way, there have I had failures? Yes. The failure rate is not being able to get what I believe is sufficient expansion. Is that after initial surgery exam is not, you can't expand, not successful, blah blah. Then what I tell them is, if I don't feel like it's something that, if it's something that I could do better, I tell them, you know, we need to stop.
Mm-hmm.
You need to heal. If you still want me to do it, you let it heal for 9 months or whatever. You come back, I'll do it again.
What does a failure mean to you? Do you have asymmetry sometimes? How do you prevent asymmetry? How do you deal with it when you
Well,
see it forming?
I tell every patient, well, none of us are perfectly symmetric. That's number one, right? Number two, every expansion pattern can have a little bit of asymmetry, okay? But you don't want the asymmetry to be noticeable, and you don't want the asymmetry to be affecting your orthodontic result. Okay, so I follow patients, so I can see what's happening, right? Every other day, I'm watching them, right? Sometimes I say, hey, you know what? You're turning too much because you're pushing the tooth. This is not what patients do. So I'm their coach, right? So it's now you know why that the way that no one does it, because it's so labor intensive. It would have been much easier and much more economical if all I do is MMA. It's easy. 3-4 hour surgery. They come in town. I operate. They stay for 10 days. Out they go. Done.
Mm-hmm. So you're saying that asymmetry cannot necessarily be prevented, but it can be managed. And management means not letting it go too far. And management essentially means not letting it get out of hand to the point where you have an orthodontic disaster that takes years to correct, with tooth tipping and intruding and
absolutely.
and MMA being required to fix the cant.
This is the problem. MMA cannot really correct significant facial cant because you're talking about the zygoma.
Right.
You're not just talking about this part. You're talking about the entire face. I've seen them.
I have too. So these severe MSC asymmetry cases where, and there's one very famous one that's been posted on Reddit, and I could screen share that.
I don't want to, you know what?
That's fine. But you can see her whole face is like this, and the whole left side is down. Her bite plane is off, and her midface is off. You're saying surgically you can maybe fix the bite plane, but this part of her face is always going to be lopsided. Is that right?
Unless you do midfacial reconstruction, zygomatic osteotomy, and
or maybe you could camouflage it with an implant on the other side, or
sure.
But now you're getting messy. Now you have a mess that you're dealing with, basically.
Right. Now you have a mess.
Yeah.
Okay. Now, let's talk about, we're on the right topic. The diastema formation. People are getting, 7-8 millimeter diastema. Why is it that there are plenty of patients that have no diastema.
How is that possible to have a maxillary expansion with no diastema anywhere?
Well,
anatomically.
Because it's a midface expansion with palatal expansion. So if you look at my 3D CT, like I said, there are 100 cases, at least. Look at the CT scan. The expansion is a pure midfacial expansion. So it's really a midface expansion, but the teeth, most of the people with a little bit narrow jaw, their teeth are flared out like this.
Right.
Okay. If you look at them, their teeth are sort of angled. Post is more straight up and down. Just look at the CT scan. I'm not gonna look. It's out there, right? I'm not faking it. Just look at the CT scan. Look at how so basically, and the teeth. Because I'm not dramatically changing the alveolar. But by the way, people say, "Oh no, you're not widening the palate." Oh yeah, I'm widening the palate significantly. Look at the pre and post.
So patients are getting more tongue space with ease?
Absolutely. They get better tongue space because if you're doing the alveolar expansion, you're doing kind of this. And let's move on, okay? And this is a good topic. This is a good segment. Okay, so I'm not saying that the ease is, I'm not saying that MSC or Marpe is bad. I'm saying that it's their limitations, okay? So this is typical. This patient I just saw last week. Middle-aged guy, can't breathe through his nose, wakes up all the time, typical, okay? Mm-hmm. So left is before, right is the MSC. You can see the tipping of the alveolus, yes?
This is MSC.
This is MSC. 6 screws. 6, okay?
So
But you
it's
get the cone shape expansion, right?
I
On the far right.
I I can't say that I'm necessarily seeing a conical expansion here, but
At home, later on, you could blow it up. You could see that from the first molar and back, there's no expansion. Okay, and
right,
you okay.
right.
So that's fine, but that's the pattern of expansion that I published in 2018 and all that. And why did I develop the ease? Because that's what I was getting with SARPE. And these patients are not better. I mean, the 10, 12 millimeter expansion, and God, you know, it looks great, but they're not breathing. They're not better.
Or does it look great? Maybe it, because some people are saying now the conical expansion is actually very ugly.
It is ugly. It is ugly because they're widening the nose. Okay, they're just. I mean, it is. But look,
it's unnatural. It's an
it's
unnatural shape of the face.
right. Okay, so. And I'm not saying that you can't do a decent expansion, decent, but you could see that, you're gonna tip the alveolus, right? Okay, so now this guy comes to see me because he's not better. I mean, he's a little better in terms of the nasal breathing, but still significant nasal obstruction, still sleep symptoms. Okay, I look at him and evaluate him. I say, you know what? The first thing you need to do is fix your sinuses. He's got polyps. He's got all this stuff. Okay. I'm an otolaryngologist. It's not just about, he goes, I'm interested in the ease. I said, no, you need to address your significant sinus problems and address them. I think your nasal breathing will be better. Maybe you won't need the ease. So you have to pick the right problem to fix. Does that make sense?
Yeah, but wouldn't you rather have him try the ease and then maybe he doesn't need the nasal surgery instead of trying the nasal surgery and maybe he doesn't need the ease?
No, it's not nasal surgery. It's sinus. You have to manage the sinus. He's susceptible to develop sinus infections and has polyps. Even if I do the ease, those things will persist. And I'm not recommending the right treatment for him.
But when you expand the nasal floor with the ease and up into the nose at the level of the bone, doesn't that sometimes make more space for the soft tissues?
It will make more space, but like I said, I'm also an otolaryngologist.
Right.
Looking that he's got polyps growing into the nose, obstructing the nose.
There's no space there for air at all.
He must address that. And potentially addressing that, he won't need the ease. Maybe his nasal obstruction is more related to his sinus infections and polyps than lack of nasal space. Does that make sense? Okay. I'm not a technician. I'm a doctor. So it's the diagnosis. Okay.
So would you say, as a general rule, would you say that you do sinus surgery before skeletal expansion?
No, not that. It's just for this particular case.
Okay, because he's got especially severe nasal blockage with the
polyps.
That is
correct.
Okay, but for a lot of patients,
look, you have severely deviated septum. By the way, people ask, oh, should I do a septum or should I do the ease or whatever? This is my experience. Obviously, the two procedures will address different component of the nose. Okay. But so doing both will be the best. In my experience, ease is going to give a better result than nasal surgery and less invasive, but albeit prolonged, and then you need braces. Okay. But there are patients I'll say, you really would benefit from this nasal septal surgery. And I tell them, look, I do a couple hundred noses a year. I'm more than happy to do the nose, but you don't have to come to me for septoplasty. You could do the septoplasty, see how it goes. It's look, at the end of the day, like I said, people come for me for opinion. My objective is not, let me do your operation. My objective is to give them the proper information so they could decide what they want to do. Okay. So
Now, does doing a sinus surgery complicate a
no,
nasomaxillary expansion at all?
no,
What about in the case that in a septoplasty, when the septum is significantly shaved down, can that lead to a complication when in the maxillary split you get some sort of collapse of the septum?
no.
Okay.
No.
Okay.
Okay.
So you can do sinus surgery first and you still have a completely open door to doing a nasomaxillary expansion later, or even an MMA later.
Sure.
Okay.
All right. 8 screws, right? So let me again, it's not that you can't get an okay expansion with MSE, okay? You can see the patient is expanded, but the teeth are bent, right? The alveolus is bent outward, yes? We agree or disagree?
I agree to some degree. There's definitely some tipping at the molars.
Yeah. Okay, and it's going to reach a limit, right? And that, you know, you're going to tip it to a certain degree, and then okay. So what it does is that I'm not saying that you can't achieve a certain. This patient is, I don't know, 30 or something. Okay, so you can achieve it. I'm not saying that it's not impossible. It's possible in some patients, but is it predictable? No. I don't think so, because I see so many failures. Unless you show me, look, I've in all my lectures, I think I've demonstrated plenty 30-year-old, 40-year-old, 50-year-old, and 60-year-olds. Yes.
Mm-hmm.
So please don't show me 20-some, early 30-year-olds. Please show me something a little more convincing.
Right.
Okay. So you can see how much.
You're saying, doctor, with age, that the bone doesn't sort of reach a certain level of rigidity where after age, let's say 30, it doesn't get any harder and stiffer than that. It just keeps getting stiffer.
It does. Oh, no. Look, everybody talks about age. Age is a major component of the stiffness. What I'm saying is that with MSE or Marpe or whatever that people are saying, it becomes harder and harder. So the cases that I see, okay, maybe they'll show a 30-year or whatever, that's a successful case, but show me something a little more challenging.
Why is a 60-year-old male harder than a 30-year-old male if the 30-year-old is fully fused?
Oh, no. The bone, look, the bone is much, it's the suture line is denser. It's harder to expand. That's the thing, is that, you know, I see all these successful MSE Marpe cases. Don't show me a 25, 28, 32-year-old woman. Don't show me a teenager or a 21-year-old man. Show me 40, 50, 60-year-old men or women or middle age. And don't show me one case. Show me many cases, because that's, you cannot compare the result of, look, I think MSE is great, apply properly. Like I said, I've done plenty of MSEs, okay? It depends on the patient. It depends on how you do the surgery, right? Yeah. So all these people say, oh, MSE works with 8 screws or what have you. You know, you could show successful results, but how many successful results and how predictable it is. And by the way, let me get back to the MSE and the screws. So you're going to expand to a certain degree, right? So why does this patient come to see me? Because his nasal breathing is only improved a little bit. By the way, he has empty nose syndrome, and he still has significant sleep apnea. He's very symptomatic.
Empty nose syndrome from the MSE?
No, from nasal surgery.
Okay.
So, you know, I mean, he's expanded, but could he have a better expansion?
That looks a little asymmetric to me as well.
Wow.
Looks like it's gone uphill on the left side.
Yeah. So could he have a better expansion? In my opinion, yes, he could have a better expansion. I'm not saying that MSC, custom Marpe, whatever you want, you use, can't get parallel posterior opening in some patients. Okay, that's not what I'm saying. I'm saying you have to look at expansion pattern, because at the end of the day, what are we trying to achieve? We're not trying to
Improvement of
achieve an
symptoms.
intermolar distance of 32.
Right.
That's not why he's coming to see me. I'm trying to improve this patient. Yes?
Correct.
Okay. We don't have to go through that. So, by the way, this patient is going to have MMA because he's very symptomatic. Okay.
Mm-hmm. Mm-hmm.
Of course. And by the way, you know, look, I know people, I'm sure I rub people the wrong way. Okay. What, you know, when I decide to continue, and really I'm enjoying, at the end of the day, I want to enjoy practicing. Otherwise, I will stop. If I'm not putting on a good product and I'm not enjoying my practice, I will stop that day. Okay.
Mm-hmm.
But the reason that I really want to continue is because why am I so outspoken about all this other stuff? Just like you, I think you're doing a service because there's so much junk out there. And I feel like it's my obligation to talk about all the, look, the people that are doing these things are not, that's not their intention, but they're so, you know, they're so false product, false promise. Okay.
Sure.
So
they don't know what they don't know.
They don't know what they know. They don't know what they don't know. Okay. Yeah. Now, I'm going to stop. This is my most recent talk. Just one patient, but we don't have to talk about it because I want to really emphasize on the nose. Okay. I've been doing MMA for, as you know, my entire career. I still do a lot of MMAs, but I see a lot of MMA failures. I have failures myself. It's not an NR cure-all. Okay. And there are a lot of nuances of MMA, but nasal, why do I talk about the nose and why do I do so many E's? I guess, you know, people come in, you know, why do you do so many E's? Well, I only do 3 operations. I recommend a lot of different things, but I only do 3 operations, and E's is one of them because it improves the nasal breathing, improves the airway resistance. In my opinion, it prolongs the MMA success.
Mm-hmm.
Okay.
So MMA is not a replacement for E's when it comes to nasal breathing improvement?
Absolutely not.
Okay. Can I show you a clip and have you react to it?
Sure.
Get the same volume. You're just getting the stuff inside still occupies that volume.
Mm-hmm. I don't understand. So you're saying that expanding the floor of the nose doesn't necessarily expand the nasal breathing tubes?
Doesn't do anything. How can it? It's just imagination, right? Get the same volume. You're just getting the stuff inside still occupies that volume.
Mm-hmm. I don't understand. So you're saying that expanding the floor of the nose doesn't necessarily expand the nasal breathing tubes?
Doesn't do anything. How can it? It's just imagination, right?
Okay. What's your reaction to that, doctor? He was saying he doesn't believe in nasomaxillary expansion at all, in that to expand nasal volume you need MMA, or at least his kind of MMA.
I don't know what his kind of MMA is. I've not heard of him. You know, I don't know what to say. I do want to say a couple of things. Now we're talking about
Okay.
nasal volume. Okay.
Okay.
At the end of the day, it's not expanding the nasal floor, right?
Okay.
It's expanding the midface. So because the nose is just an empty, it's, there are a lot of things in it, but really in the skull formation, it's composed by the two halves of the midface, right? It's a hole or it's a tube. The two halves composed of the walls of the nose. Yes.
Mm-hmm. Mm-hmm.
So it's not just about people, sure, you could set expanding the floor, but really, I like to look at it as expanding the midface, because, in my opinion, I don't have it. Look, people's going to, oh, you don't have any data. No, I don't have any data. This is just observational in my clinical experience. I think expansion of the posterior is is very important. And I think expansion superiorly is very important as well. Okay. That's why in ENT, when plenty of patients have significant turbinectomy in my years of ENT as an otolaryngologist. I've seen them. Okay. So when you look in the floor, it's huge. There's barely any turbinate. I mean, you see all the way to the nasal pharynx. Yet the patient has problem breathing through his or her nose. The superior expansion, whether it's so.
What do you mean when you say superior expansion?
Let's say, and that's why I show the geometry. The geometry. So
Yeah.
you can imagine a nose is a 10, right?
Mm-hmm.
You could expand the nasal floor like this, okay? Or you could kind of expand a little bit like that. A little bit like that, in my opinion, is better than this.
Mm-hmm.
If you go back to thinking of geometry, or maybe there's some sort of sensor, I don't know. If Christian is still alive, he will start talking about sensors, but look, I'm just a plumber, okay? So, but clinically, that's what I believe.
I think you're a framer, because I think what you're talking about is you're talking about taking an A-frame and turning it into almost like a lean-to that has more of a square shape.
A little bit, a little bit.
So maybe with Paul, maybe the problem that spawned Paul's response that a lot of people are reacting very negatively to, saying, come on, that's ridiculous. Of course we get improvement in nasal breathing with nasomaxillary expanders. Maybe it was my fault that I phrased it as the floor of the nose. Maybe I should have been more precise in saying overall three-dimensional nasal volume expansion, superior, inferior, and everywhere in between.
Well, yes, I think that's obviously, I believe that's the ideal expansion. So when you do that type of expansion, you don't have to expand so wide and create a huge diastema, right? Because it's a lot more efficient, right? And you don't have, and you reduce the risk of dramatic expansion causing asymmetry.
Right.
And by the way, when I expand, it's all about clinical improvement, right? I'm going to expand beyond, they tell me, oh, I've been expanding for the past few weeks. I've not noticed much improvement. And I'll say, you know what? I don't want you to keep on expanding because there's no reason to push the envelope. Let me just address, I assume that the interview he's an oral maxillofacial surgeon.
Yes, in Australia, a very well-known Australian surgeon, Paul Coceancig.
Okay.
Very nice guy as well.
Yeah. Okay. Well, we're talking about the nose, right?
Yes.
That's not in the training and experience of oral maxillofacial surgeon. They don't do nasal surgery. That's not what they do. That's in the realm of otolaryngologists. That's number one.
Okay.
Okay. Number two, a lot of people ask me, Sure, some oral surgeons, very few, they may learn facial cosmetic, but look, I've done hundreds of rhinoplasties in my career, so I think I could say that. But anyways, if you're talking about orthodontic surgery, okay, you could bring up your skull, Ron, your fancy skull. All right. Well, you know where the Lefort cut is. The Lefort cut is right here, right? Yes?
Yeah, it could be high or lower depending on
Well,
Lefort 1, 2,
basically,
3,
you
but
don't want to do a high Lefort cut because that is going to get into all other aspect. So
it's a whole different surgery, sure.
typical Lefort is, couple 3 millimeters above the nasal floor. That's a typical Lefort cut.
Sort of right along here.
Yeah. Okay. And you're not going to influence anything in the nose above that Lefort cut. Nothing. Agree?
I agree because the lever is being cut off there, right?
Yeah. Okay. So people talk about, all you need is, look, by the way, MMA does improve nasal breathing some.
Can you explain the anatomy of how MMA improves nasal breathing? Because Paul asserted MMA will improve nasal breathing, but wasn't clear to me as to the anatomy of how that works.
Well, first of all, if you, I thought he knows about, you should have asked him. You should have asked him about why MMA improves nasal breathing.
I think I did. Maybe I did. Maybe I'm just not recalling his answer, but I can remember that whatever he said did not stick. So,
well,
for what that's worth.
Let me explain from an otolaryngologist standpoint why does nasal breathing improve with MMA? Number one, if you are doing a bit of a counterclockwise rotation, you are increasing the nasal volume.
From below.
Well, here's the maxilla, right? Here's the soft palate, okay? Here's the ANS, yes?
So your elbow is the front of the maxilla, your hand is the back of the maxilla,
Right.
and the soft palate.
Okay. So if you're going to do a counterclockwise rotation, you're doing this, right? So you're increasing the height of the nose on the length of the nasal volume. Yes, the nasal,
right.
The nasal overall nasal dimension, not so much in the front, but in the posterior. Yes.
Yes.
Okay. That's
you're adding a basement, not an attic.
Correct. That's a good that's a good analogy. Okay, that's number one, but not dramatic. But what really improves the nasal airway is the advancement of the maxilla. Okay, you are basically expanding the nasal valve. You are enlarging the sort of the meaty portion, as I call it. You're advancing it, so you're expanding it. So there's that's more of a impact than, because not every patient has counterclockwise rotation.
Right. Really, in MMA, not every patient has counterclockwise rotation.
Not every, depends on what they need.
Right. Just to be clear, when you say the nasal valve, does that refer to like right here?
Yeah.
So the
external valve.
Okay, so like sort of the entry to the nose gets bigger.
Yes.
Okay.
And when you expand, sometimes, I mean, it lessens the collapse, because you're creating a little scarring, you're this and that. So overall, people generally notice a little bit of improvement in nasal breathing. But is it equal? Not even close to ease. Okay, so you see the distance between my palms?
Yes.
Do you feel like this is bigger than this?
I know it is.
It's not an imagination?
No. while we're on this subject, let me ask you about the effect of a 3-piece Lefort on nasal breathing.
Yeah.
Can I show you? Yes.
Yeah, go ahead.
So let me show an image, just because this is hard to visualize for a lot of people. This is actually an image created by a member of my Discord named Shuikai, who everyone in my Discord knows who he is because he's a very active member, a very brilliant young man. So from Shuikai, he wanted me to ask you specifically what you think about something like this to improve nasal breathing. Let me make sure and I am. The share is fine. What are your thoughts on this, Doctor?
All right. Let me just say this. When you do a multi-piece Lefort,
yes,
okay, the limiting factor is the palatal mucosa. Okay, because you can't stretch very much. Make sense?
Which is to say the skin at the roof of your mouth.
That's correct.
Okay.
Okay. That's number one. Number two, now, sure. So it depends on how much you're expanding, right? So let's look at the Lefort cuts. Okay. And this is a very good point. Let's look at the Lefort cuts. The Lefort cuts, we all know what Lefort cuts are, right?
Yes.
You see the nasal piriform area and compare to the zygoma. You see how the cut is slanting downward?
You're talking about this cut here. Is that right?
I don't see your point.
Where the purple or the green meets the gray above it.
That's correct.
Yeah.
You can see that it is a physical impossibility to widen the maxilla with that type of cut. Because the zygoma area is lower, right? You can't push beyond that. It's blocking the way.
At the edge of it.
Yes.
Yes.
Does that make sense?
Yes, it does.
Okay. Which gets me to the point about dome and SARPE. And because I just see it done so incorrectly, depending on your objective. That's why when you do it SARPE, dome is same as SARPE, but whatever, I see the cuts like this. Are you going to, how it's going to expand? It's going to hit this point on the edge, and it's going to do this. It's not going to expand. Does that make sense?
Yes.
What are you? So everyone could do a cut. Everyone could use a saw. But why are you doing this?
Yes.
Okay. So that cut is a physical impossibility. Does that make sense?
Yeah, because two solid objects can't occupy the same space.
All right. So even let's say you straighten out, let's say you make because the only way to widen is to make a perfectly horizontal cut, parallel cut, right?
Correct.
Okay. So what does that mean? That means that you have to really lower the cut toward the nasal floor.
To below the zygoma.
Yeah. Well, you have to, you could cut at, yeah, exactly.
Yeah. And now we're talking about only inferior nasal expansion, because the superior has to be above the cut and therefore is not being affected by the expansion.
Let's talk about simple geometry now, okay? Now we're going to talk about simple geometry. Look, what's the height of the nose? It's all the way up to the cribriform plate at the roof, at the attic. It's very tall. Makes sense?
Is that sort of up near where the eyes are? Is that?
Yep.
Okay.
Okay. You see how tall it is, right?
Yes.
So when you so when you are expanding just a millimeter, look, I'm not here to. You could get on CAD and start doing experiment. This does not. So even if you do a multi-piece Lefort, 3-piece, you're not going to come even close to a 1 millimeter nasomaxillary expansion.
Right, because it might be a narrow width that you're expanding, but over the length, width times height gives you the area, or times depth gives you volume. So you have to account for all of that to determine the nasal volume change that you're getting with nasomaxillary expansion.
That has been a central, you could say, argument or whatever, compared to other types of expansions. It's much, much more efficient the way that EASE is done. You've seen enough CT scans. I've shown you how it's done. Yes?
Yes.
So I know you look, I also do segmental osteotomy. I don't like to do them because I don't think they're very good. By the way, it's not easy to move the posterior segment, the 3-piece, okay, horizontally, because you got to pull the palatal skin.
Right.
You got to stretch that, right? It's not easy to stretch. It's very taut. Right. And you have to make the bite fit. Because you want to make sure the bite is right? So
of course,
you put into the splint to wire in, okay, to fit, and then you put a little bone graft. I mean, look, okay, we're talking about surgery now. So a lot of times you are not doing this, but you're kind of doing, kinking here and there to put the. So it's not nasomaxillary. It's not expansion. It's basically you're kind of tilting. It's a lot of tilting to fit it into the splint.
Right. Wow, that's the best explanation of why it's better to do a nasomaxillary expansion for transverse dimension and for nasal expansion than it is to do a 3-piece Lefort.
Well, I mean, the 3-piece Lefort, I mean, it doesn't even come close. It doesn't even come close because, number one, you can't make a high cut because of the zygoma, right? So it's got to be a low cut, number one. Number two, you're not doing this. You're doing, you're trying to fit it into the splint.
Yeah, you're finagling the bagel. Yeah. Wow.
Look, I could talk about surgery all day long. Okay,
I could talk to you about surgery all day long. God knows I have a whole list of surgical questions I wanted to ask you. We're already at 2 hours and 25 minutes. I don't know how many we're going to get to, but I just want to make sure I'm understanding what you're saying about what makes EASE special. What makes EASE special is really the depth of EASE up on the y-axis into the superior part of the nose. That's what gets you the height dimension of the volumetric calculation where you're determining how much nasal volume you've gained. The EASE, it's almost like if MSE and SARPE, I'm sorry, if MSE and custom Marpe expand conically, the EASE almost expands conically on the vertical dimension. Is that right?
Yeah, you'll find if you look at the CT scan and done measurements, the maximum expansion is actually at the nose, because that's where the force is applied. Bone is going to react more where the force, you could talk about Wolff's law or whatever. Okay. So it's not 1-to-1. So the nose portion is the maximum expansion. Just look at the CT scan, look closely.
What's not 1-to-1? Suture, the ratio of the
Nothing is
sutural
1-to-1. Nothing's 1-to-1. The mid-palatal separation and the nasal piriform rim is not 1-to-1. The the superiorly is not one-to-one. The zygoma is not one-to-one. It's things. We're not dealing with talk about construction. We're not dealing with a 2x4. You know what I mean? We're talking about a skull, and there's three-dimensional change and all that stuff. But if you do not want a wasted movement that could cause dramatic change and often not favorable changes, in my opinion, if your goal is to achieve an efficient nasomaxillary expansion, I believe it's ease.
Ease is the best ratio of dental change to nasal volume change.
In my experience, yes.
Yeah.
In my opinion, I'm sure you'll find someone who will tell you that it's an imagination.
Because when we talk about essentially all of the negative potential consequences of nasomaxillary expansion, they all have to do with excess or undesirable dental change that results from.
It's not just dental change. It's skeletal change, and
Sure.
look, there are a lot of different factors. But look, I'm not saying ease is perfect. It's not perfect. It's difficult to do. By the way, it's not how deep it's cut, but I'll just say at the end of the day, it's how you separate, how you expand. Okay, I make sure, and the way that I do the surgery delicately is to open up the suture, which I tell you is achieved at the end of the procedure. It is not a massively invasive surgery. In fact, you could see these patients 2-3 days after, the same day after surgery, right?
Yeah.
And but it's extremely labor intensive. It's very delicate. It requires different skill sets from different specialties, and requires it's just very labor intensive. Okay, but why do I do it? Why don't I just continue to do MMA? Because I get the results.
Yeah.
I'm not saying that I help 100% of my patients, but I tell you 95% of the patients are improved. Now, why do I only do 3 operations? If you look at what I've done, look, I used to do blepharoplasties, facelifts, rhinoplasties. I've done jaw surgeries, nasal surgery, UPPP, genioglossus. I mean, I've done, all the sleep apnea surgery, all the facial cosmetic surgery. I put, implants and zygomatic. Look, I've done a lot. Why do I, and, I enjoy doing, this only the 3 surgeries that I do. Why do I do that? If my objective is to improve patients' breathing and sleep.
Yeah.
This is the problem that I have with sleep surgery. Early days, I stopped doing UPPP and genioglossus advancement probably about 10 years ago.
Why?
I can't stand when patients come back to see me a few weeks later. When I see my patients a lot. When they come back, I ask them, "How you doing? How do you feel? How's your sleep?" My heart just sinks.
Yeah.
Okay. If I'm going to do an operation, I want to see positive results. I want to get something out of it. Okay. I don't want unpredictability. Not every surgery is the result is 100%. Okay. Nothing's guaranteed. Nasal septoplasty, if you look at the literature, success rate is probably 90, I think 92, 93%. Okay. I would do nasal surgery. The nose is widely open, septum is straight. How's your breathing? I don't notice much improvement. Okay. So the reason I do those 3 operations only is because it's highly predictable. I'm going to get something out of it, and patient's going to get something out of it. Mm-hmm. That's why I do those operations. Mm-hmm. Mm-hmm. I'm not saying that pharyngoplasty or whatever don't help. you know, I've done them my entire career until a few years ago. So, they can help, but they're just less predictable. And I don't like unpredictability.
Yeah. Can you talk about the role of pterygomaxillary release in your ease procedure? And are there any other places where you release in order to facilitate the expansion? And maybe I'm wrong. Do you even do pterygomaxillary release? Because certainly the rumor is that you do, but I don't know. You can tell
Yeah, I
me
do. I do a piezo delicately, and
here. This is this is the
yeah,
pterygomaxillary area.
yeah. That's where they get look. They get swelling in the cheeks because of the pterygoid separation, and they get some nasal swelling from the manipulation of the scope and in the anterior maxilla. That's where they get the
Are,
swelling.
are there any other areas that are released besides mid palatal and pterygo?
That's it.
That's it. Yeah.
Look, it's how the surgery is done delicately, and it's how the expansion is done during surgery and post-op for months. Okay, it's not so everyone's different. Some patients that I expand a little bit more. Some other. So now I know everyone wants to hear about. So because it's pure skeletal expansion, look, I want to make sure that people understand. I'm not saying ease is 100% successful because it isn't. Okay.
Mm-hmm.
I like to make it 100%, but I can't. There's been a few failures and the result is not as good as the patient wants and as I want. But are they the minority? Yes, they're the minority. Okay. Very minority. But so why? So that's why I follow patients very closely and tell them how much to expand and watch them. When people do MSE and what's going to happen with FME, first of all, I hope you agree that the anatomy doesn't change, right? Anatomy is anatomy, okay? That's why the FME is going to have problems. And I would tell you, I believe the FME is going to have more failures than custom MSEs.
Why is that?
Well, because you are using, look, we're talking about a company who's going to develop the product and sell the product. Yes, everyone's going to do it, right?
Yeah.
TMJ dentist.
Yeah. I can just
Everyone.
see it now on the website. I can see it now.
Yeah.
There's gonna be a tab at the top. It's gonna say
Providers.
no on the TMJ dentist website. It's gonna say uh, restorative dentistry. Then it's gonna say TMJ/sleep apnea. You're gonna click the tab and it's gonna say AGA, ALF, Vivos, FME.
look, joking aside, okay.
I know.
I
I'm
work
kidding.
with TMJ specialists because they are TMJ specialists and splints and that sort of thing. But
Sure.
but some TMJ specialists also do sleep and do a lot of these things which I don't believe in. Okay, so hence the humor. Okay,
Yeah.
so
Yeah.
the device is going to be much. Look, I mean, we don't have to talk about cost, but the device is going to be very much more costly and much more difficult to place. Now compared to the custom MSC, so when because I'm expanding skeletally, I sort of look again. Surgery to me is an art. So when I expand, I'm feeling the force, right? So I determine, okay, how much force to expand. So I tell the patients that's why I watch the patient. I go, hey, this guy, the skull, and you can't turn too much. So I keep tabs on them, right? How
It's
much
a
do you turn?
dance.
I'm sorry?
It's a dance.
It's a dance. How much do you turn your MSC? You know, how do you feel the force? Because is when you turn, is it affecting the sutures? Is it tilting the teeth out? Is it cheese wiring the screws? Is it bending the screws, tilting the screws? So the whole system is supporting it, right? Okay. So you may be turning too much, right? So what's going to happen? The teeth is sort of supporting it rather than the tats, right?
Yeah.
Okay. So, but that's the way that expansion works. Then okay, that's the way expansion works. But I'm just going over how much do you turn? You know, is it different for you versus a 50-year-old? I mean,
Right.
it's the same for everybody, right? I mean, it's the same.
Yeah. One turn a day.
One
Good
turn a
luck.
day.
See you in a
Okay.
month. See you in a month.
Okay.
Right.
See you in a month. That's a problem.
Yeah.
Okay.
And I can tell you as a patient, you have no idea what that appliance is doing when you're turning it. You feel.
Exactly. You have no idea,
Yeah.
and the person placed it has no idea.
Yeah.
I'm gonna get a lot of hate mails, but what are you doing? That's my question. So why is custom MSE Marpe? I believe it's going to get you better result than FME because you have more rigidity. Okay.
Yeah.
But the placement, okay, you could say, okay, well, the screws are, better design and where it's locking and blah blah blah, this and that, and we got 3D placement, this and that. But you cannot change the anatomy of the palate.
Right. What does it matter if the screws are locking and if they're bigger and fatter if they're going through the same paper thin bone? No, I've honestly had a very hard time trying to understand all the hype around the
Everybody
FME.
and people are coming and say, "Oh, you know what? Look. I hope it works well. It will be great if it works well. But I can tell you, it's going to be much harder to place. Okay.
Because it's bigger?
No, because you're going to place it. They have this jig, and then you're going to have to because it's going to be a lot harder to place. Okay.
Can you help me understand what the sales pitch even is of the FME? Like, try to steelman the FME for me because I don't even know if I understand how it's trying to differentiate itself from the other expanders. My only understanding of it is that okay, it's posteriorly placed. Fine. MSE was posteriorly placed too. That has problems because the bone is thin. It has no arms. Okay, fine. MSE had no arms. That has its own problems because there's less anchorage and people ended up just adding arms so that they could get more anchorage. So what's different? I don't understand. It's bigger, it's fatter, it's more metal. Maybe the appliance is less likely to get distorted because it's a more robust structure, but doesn't that just mean it's going to rip through bone easier? I'm being sincere and trying to understand
Yeah.
what's the promise.
Well, everyone focuses. Look, it's a slick design. Clearly, the company has fair amount of financial backup. They have engineered developing it. Okay, um, but you can't change the anatomy, and and how is the procedure done? I mean, people are thinking, "Oh, all I'm going to do is place this device and expand, and voila." That's not how things work.
Right.
Okay,
There's
but
always going to be a dance. No matter what the appliance is, there's always going to be a dance.
and
There should be.
you see, and so that's why I try to explain on the ease. I mean, it's people think, oh, it's going to take you 15 minutes. No, it's just it's like cooking. Not that I'm a cook, but it's a procedure that everyone's a little different. I mean, it's like a painting. That's best I can describe it. Okay, so anyways,
So you're not buying stock in FME?
well, um, like I said, I hope it works, but I think they will have a lot of failures because you will not be able to just place the device and expand. Sure, you could look. That's what I'm doing with with MSE in patients, which I assess. Look, I take CT scans. I know everyone takes CT scans, but I study the CT scans closely before the surgery because I look at the bone thickness, the depth, where there's a lot of, I put a lot into it.
But with respect to the FME, if it's not a custom appliance or even a customizable appliance, and they're committed to posterior placement, what's even the point of taking a CT if you're going to put it in the same place
Oh,
with the same TADs no matter
they're
what?
going to tell you where to put it.
They're going to tell you where to
They're
put
going
it.
to tell you, well, yeah, I mean, you have the option, I believe, of them telling you, you're going to look, this device is going to, my estimation is probably going to, if you have the 3D and all that stuff, first they have to make it out of titanium. Okay, because they need to be MRI compatible. Just, okay. My estimation at the minimum is $5,000, if not $8,000 per device
In lab fees.
with 3Ds and whatever. Okay, that's because it is a company that's going to, it's a company, right? That's number one. Number two, you're going to have your person, your doctor, place it. It is not putting in 4 screws or 6 screws. You got to, it's more to it, right? And you have to do your piezo, or I hope, and depending on where the screw is, you want to be a little careful doing your piezo, right? So we'll see.
But how is it different than a custom Marpe then? If you're just getting custom TAD placement from the lab based on a CT scan, and it's just another titanium appliance that goes like this, how is it different than a Partners Dental custom Marpe that
That's why
Lipkin and Evans and everyone is already?
I believe it will not be as successful as custom Marpe. Basically, it probably the same. I says probably the same. You're still going to have difficulty in posterior expansion. Obviously, theoretically, placing on the palate and expand, it's a little higher than the TPD than the E's. So you'll say, yeah, no, it's better. Well, that I mean, I know that. Okay, that's why in some patients, which I do MSC because it's better, but rare. I mean, they're uncommon. They're going to face the same problem as the custom Marpe, that no posterior expansion. And people is going to, well, you don't need posterior expansion. That's what people is going to say, or people are saying. You don't need posterior expansion.
No one is going to say that on my channel. I can tell you that.
Okay.
The hope in my channel is that this is somehow going to provide posterior expansion without the ease release. Just in virtue of the appliance design, it's somehow going to utilize that thin bone back there to expand posteriorly, just in virtue of the appliance design. I don't get it. I don't get it.
I mean, I agree with you.
Yeah. Well, then we're on the same page, but certainly I can tell you the hype is through the roof for this expander. I mean, people are putting off treatment in hopes that this is going to somehow be like the Messiah. They should call it Messiah instead of FME.
Well, like I said, it's like I said, you're a connoisseur of nasomaxillary expansion, and so it's there are a lot that goes into it. Number one, the anatomy.
Yeah.
Number two, how it's released.
The release is critical.
Number three, how it's expanded. What method do you expand? And how you follow the expansion. So which I spelled out in how I do the operation.
Right. Yeah.
So,
The Facegenics Messiah expander.
well,
Doctor, can I go to some of the questions on my list? Do you have a little bit more time?
I'm here to answer questions, Ron.
Okay. Bear with me. A lot of these we've already addressed. How do you determine if a patient is a candidate for EASE or if they should just go right into MMA?
That's a very good question. Obviously, if they, it's a little complicated. I'm going to go over the variables, okay? The age of the patient in terms of, the age. Look, it goes into how I assess a patient in terms of a patient with sleep apnea. Gender of the patient, age of the patient, weight of the patient, the anatomy of the patient, the severity of the sleep apnea, symptoms, if some, and their objectives. Okay. I'm a firm believer. I already said it. Until 2017, overwhelming majority of patient is MMA. MMA. If you see that patient that I didn't bring up, I operated on him probably 15 years ago. Okay, young man, which I didn't. This guy, okay, he was CPAP dependent. Okay, so
let me put the slide back up. I apologize. Yep, this is the patient you're talking about.
Right, 2009 and 2023. Okay, he was CPAP dependent in 2009. Can you see the midface? The midface retracted a little bit.
Yeah, like a relapse of the MMA almost.
It's not relapse. No, there's no relapse in this patient. It's lack of nasal respiration.
Mm-hmm.
Okay. Yeah. 2009, I was just doing nasal surgery MMA. He had no soft tissue problems. His soft palate normal and, traditional sleep apnea surgery. And he was CPAP dependent. So I did. And, he was constricted. He has nasal obstruction. So I did the MMA. He's much improved. He gradually worsened. So, I talked about breathing. I talked about the physiology. I talked about all that stuff, which I'm not going to harp on. So increased nasal breathing, in my opinion, is crucial in prolonging the success of MMA.
Right.
Okay.
It stabilizes the MMA.
Because if you are, I tell people, okay, well, the nose is the most restrictive segment of the airway. Okay. That's why, so if you talk about CPAP, a significant amount of pressure that you need is to get the air through the nose so you can treat the back of the throat and the tongue and the sidewall, yes, whatever. Okay. So if your nasal breathing is still an issue, in my opinion, it is going to shorten the success of MMA.
Yeah.
That's number one. Number two, everyone's going to age. Everyone's sleep apnea is going to worsen. That's natural history. Okay. If the patient already has symptoms when he or she's young, I don't want to see patients back 5 years, 10 years, 15 years later. I want to maximize their results. And someday they may need CPAP. Someday. I never tell patients that the MMA is going to last forever because it may very well not. Any jaw surgeon, look, if you go to a jaw surgeon, you know what operation you're going to get?
Wisdom teeth removal.
Okay. I want to get them. I want to set up a basement, meaning that if and nasal airway is a significant contributor to difficulty in using CPAP. I know people don't want to use CPAP, okay, but I want to. There are reasons why I do a lot of ease. Why? Because it's quite successful, not 100%, but quite successful. I'm able to improve them, and they have, and I get a base, okay, and it prolongs the success of MMA. Makes, in my opinion.
Yeah, that's
okay.
Fantastic.
So this patient, in my opinion, this was 2009. Okay, a bit of a long face. And, we could talk about facial aesthetics all day long. And I could talk about rhinoplasty, nasal changes, whatever you want to talk about. Okay, I don't harp about aesthetics because it depends on what the patient's looking for. I am a board certified facial plastic surgeon, by the way.
Well, I can tell you that any aesthetic comments you want to make are more than welcome on my channel, because I would say half of my viewers are primarily interested in aesthetic improvement.
Okay, well, this patient has his nose is a short nose.
Yeah.
You see the upturn?
Yes.
You do any MMA, the nose is going to upturn more. Remember, advancement is going to tilt. It's going to increase the tip.
Right.
Okay. And any MMA is going to can potentially, it will change the nose some. That's why I do a lot of. We're going to go into the esoteric of MMA. Alar cinching, subspinal, blah blah, all the stuff, design, all that. This is not the topic. So, I advanced them. Back in the day, so you could see a bit of a counterclockwise, and I think 12 millimeter advancement, blah blah. Was much improved, but you know what? You could see the gap in the mandible, right? You could see the, it's a decent advancement. It's not 25 millimeter advancement now people talk about and do. And by the way, I don't believe in that, dramatic advancement, because sleep apnea is not just the anatomy. And I repeat, sleep apnea is not just the anatomy. There are a lot of different factors. Okay.
What do you mean by that, specifically with respect to your comment on not over advancing patients?
Okay. Look, how the surgery is done and the degree and how the surgery is designed is a decision between the surgeon and the patient. Okay. Look, I do standard orthodontic surgery all the time. It's not just for sleep apnea. Those patients' desires are a little different, right? So it depends on what they're looking for. But if you're doing sleep apnea surgery, MMA, you want to maximize the advancement, okay? You want to maximize the advancement within reason. What I mean by that is that there's a certain amount of physiologic, what I call the physiologic envelope of the muscles, the soft tissues. You could look, in the old days, I used to do what I call intraoperative stretching. When I was young and aggressive, I was trying to stretch it, put in big plates and this, that, over time, there's, you can't fight the tendency to relapse when you overstretch the muscle.
Because the skin and the musculature will elastic back.
Exactly. Okay. I've seen a lot of cases. Okay. When you overdo it, you start putting HAs, bigger plates, blah, blah, blah. Still, it's the stretching, the elasticity isn't just like that. It's over time.
Yeah.
So, and at the same time, why do I see some young 25-year-old with severe sleep apnea and some 25-year-old don't have severe sleep apnea? Yeah, their anatomy is not significantly different.
That's a good question.
It's not just the anatomy.
Right.
People like to, and that's the problem that I have. Okay, you go see someone with a CT scan, took a weekend course. We're going to do MSE and you're going to have jaw surgery. It's not that simplistic. And that's why you have to understand sleep. You have to study it. You want to gain the knowledge so you could, it's not a cookbook. You have
Yeah.
to
Do you
gain
think
experience.
a lot of the so different phenotype? I'm sorry, same phenotype, different um, symptoms, right? Some people with the same facial structure will have sleep apnea versus not have sleep apnea. Do you think a lot of that has to do with soft tissue function, like
Sure.
myofunctional therapy?
It's soft tissue function. It's it's how the brain works. That's why Chris John was so interested in, because he was a neurologist. How the brain
Who's
works.
Christian? Who's Christian?
Dr. Gimeno, Christian
I
Gimeno.
don't know him. He
Wow.
seems like he was a big influence on you, though.
I worked with him for 23 years. He described sleep apnea, described URS. He's,
Is he deceased
yeah.
now? Okay, may he rest in peace.
Well, funny story about Christian. I used to go to meetings with him. People would present, and he would stand up after the presentation. I would just cringe because he's going to say something to insult that person. Okay. He's not one to hold back. Okay. At the end of the day, I'm not holding anything back. I'm here to tell people what I think. And people can disagree with me, which is fine, but you have to disagree with me with something concrete. And you have to explain to me why you disagree and have something to back it up, not just imagination.
Right. Right.
So, anyways, go on. So,
Yes.
so we talk
Yeah.
about MMA. So this is the last slide. Okay, I just got an email from this patient. I saw him a while ago. He had MMA, and you could read it. Okay, so on the left, it was my what was the email I got sent.
Mm-hmm.
Okay, and on the right was my note when I saw him.
Mm-hmm.
This is what I see, is that, in my opinion, MMA is way overdone. Unless your objective is to improve aesthetics, or if that's your motivation, fine.
Right.
Okay. You want if you're looking to have a Big Mac, you go to McDonald's. Okay. So it depends on what you're looking for, right?
Yeah.
But it's not the same treatment and the same, you look for someone with a hammer, you're going to get a hammer.
Yeah.
Okay.
Yeah.
That's what I want to emphasize, is that you want to be a little careful, is that all these people, you have an operation, fine. But what are your objectives, and is the operation going to help you? And that's the goal, right? And what is it going to help your aesthetics? Okay, maybe if that's your driving force, great. And now it comes to over advanced versus under advanced, or whatever advanced. Okay, there's no ideal advancement. Okay, it's an advancement where it's going to check your boxes, so to speak.
Right.
And how much risk are you willing to take, and how much you want to push, and et cetera, et cetera. And sometimes it doesn't work out. Sometimes it's not successful, like this patient. And I get that myself, but I don't want that, right? It's not just about doing an operation, it's about being happy. Both I'm happy and the patient's happy at the end. So go ahead with your questions.
So just to wrap on this point, with regards to sleep apnea, you're only as good as your weakest link, and the nose tends to be the weak link with sleep apnea. So if you do an MMA without addressing nasal volume blockages, then you end up right back where you started, in the medium to long term, sometimes in the short term. I mean, this guy did MMA in August 2023, and immediately he knows he's still not breathing well through his nose. And that's going to be problematic for his goal, which is to improve his sleep apnea.
I've seen patients with, oh, I'm really happy with my cosmetic result, but I still can't breathe through my nose, and my sleep is still, I still wake up in the middle of the night. Well,
Yeah.
It depends on what you're looking for, right?
Now, is ease okay to do after MMA, or does MMA complicate doing ease on a patient?
I tell patients that it's always more, because you want the midface to be rigid, right? So I tell them, theoretically, ideally, I like to do the ease before the MMA. Okay. However, have I done many eases after MMA? Yes. Have they improved? Yes. Just like that first patient from New Jersey, he had MMA,
Sure.
and he's still symptomatic, and I see that all the time. Okay. Yeah. So this morning I said, how's your nasal breathing? Better. Yeah. I'm not saying everyone needs to have the ease. So it depends on, you have to look at the nose. A lot of times I say, hey, you need to address your allergies and this and that. You have to look at the nose. You have to examine the nose. You have to talk to patients about symptoms. You have to look at the anatomy. And there are a lot of different variables.
Yeah. All right, let me move on to the next question, doctor. What's your opinion on protraction to be done alongside of ease? This is also known as face masking, specifically with regards to class 3 patients. Dr. Lipkin has some cases where he's corrected class 3s by adding a face mask to his custom Marpes. He puts arms on the custom Marpe coming on the buccal side, and he's corrected, I would say, 5 millimeter deep class 3s. Have you ever done that? What do you think about that?
What's your objective? To correct class 3s?
To fix, in this case, I would say to fix the malocclusion.
Okay. If your goal is to fix a malocclusion, you could have protraction. Basically, if you really critically look at the before and after. Mm-hmm. Number one, depends on the age, right?
Depends. Dr. Lipkin's cases are men in their 20s, early 30s, yeah, I would say.
Like I said, depends on the age.
Okay.
Number two, critically look at the alveolus. I've seen one of the, I'm not saying it's the person that you mentioned or the orthodontist that you mentioned, but I've seen another orthodontist that, pre and post, overwhelming majority of changes, and this on a woman in the 20s, overwhelming majority of changes is alveolus.
Of the protraction?
Yes.
What's happening there? How
do you mean? The alveolus is being tilted.
Of the upper segment?
Yes.
Of the upper front segment?
Yeah. Well, the entire segment is being, yeah, and it's being pushed forward. That's how you correct class 3, right?
I see. So you're saying the face mask is not actually pulling the midfacial bones forward, it's somehow only grabbing the alveolus and tipping the alveolus?
Mostly, yes. At least from the CT scans that I've seen. Maybe people would disagree with me. That's fine. Look, I've done a lot of bolars. You
A
know what
lot of
bowler implants are?
the Bowler plates.
Well, yeah, plates.
Explain it to me.
Bowler
Tell us how that
basically is
works.
done on teenagers
Okay.
and kid or teenagers. So basically for midface protraction. Okay, these are so basically yeah. So you attach onto the sort of the root of the zygoma, and you apply rubber bands, and you're going to protract. Can you get some improve? Can you protract the midface? Yes. It depends on the age of the patient. Okay. Have I had the orthodontist had a lot of failures? Yes. So depends on the age, depends on what you're trying to achieve. Um, you know, there are a lot of look. Are you going to get a 5 millimeter midface advancement? I haven't seen the data, but it's a little hard for me to believe.
Okay. Okay. Fair
Okay.
enough. And I think that's all very reasonable. And I again, and when we get back to your earlier very nuanced points about it being a dance, of course, protraction also requires the patient to be willing to wear the
Absolutely, absolutely. Okay.
15 to 24 hours a day. Good luck.
Good
Hey,
luck.
if you're committed, let's go for it, but let's expect mixed results maybe.
Yeah.
Okay, you not something you're generally interested in doing because you're not an orthodontist, you're not here to fix malocclusions primarily.
Remember, I said I'm the world's worst orthodontist.
Yes. Fair
By the way,
enough.
I'm the world's worst ear doctor as well.
The world's worst.
I am a ear, nose, and throat, but don't ask me any questions about ears.
Fine. I will not. I won't ask you about the biggest piece of earwax you've ever removed.
I removed some early in my years.
MSDO, mandibular symphysial distraction.
Yeah.
Does that play any role in your repertoire of tools?
Depending on what you're looking for. But in short, no. I published that in 2001. Okay.
What did you publish? Forgive me. What did you publish?
I published on maxillomandibular expansion, MSDO, and SARPE.
Mm-hmm. And what was your conclusion?
There were improved some, okay, but over the years I've done them. This, and I wrote a paper for the French orthodontist. Widening of the mandible with MSDO is not going to help your airway. Okay, it's published over 20 years. If you're going to convince this is the problem that I have. All these people are making these claims or are saying all these things. Show me the data, and show me the data, and explain the physiology to me.
So to be this to strawman the MSDO, I think a few things are going on. One thing that's going on is that because most nasomaxillary expanders create a huge amount of, let's call it, change in the maxillary widening, which is to say,
with a Marpe.
With the Marpe, that the only way to get the patient back into an occlusion, if you want to really expand a lot because of the lack of efficiency, perhaps, you're having to get these big 10 millimeter expansions up top. The only way you can get the bite back is to expand the mandible similarly. So I think is that part of it, that the inefficiency of the Marpe forces you to then do a mandibular expansion just to get occlusion?
Yes, that's why and I would venture to say, so look, I'm a surgeon, okay, but my goal for treating patients is to improve patients with the least invasive and the least number of surgery that I can do. Okay,
Yes. Yes.
you're you're talking about mandibular distraction. Look, the surgery is not difficult, but look, you have to mess with the distractor. You got something under your lip. I've been there, done that. Many cases, early on. It's and you know what? You get a broad look. If you have a narrow jaw, okay, but you get a broad chin. Does that make sense? It's
Yeah.
going to widen like this. It doesn't look natural. I hate things that don't look natural.
Mm-hmm.
So just because, look, we're all surgeons. Surgeons, look, we're all arrogant, okay? We all think we could, oh, look, I did this, I did that. But what are, at the end of the day, what, when I do, I'm not going to speak for other people. When I do an operation, I want to know what I'm doing for the patient, okay? And to me, you do a huge expansion with the MSE. By the way, are they getting good results? Because the expansion, a lot of it is dental-alveolar expansion, right? So then you have to do the mandibular widening. It's so much surgery, a lot costly, and you got to suffer through those surgeries. And are you achieving the result that you're getting? While I'm at it, I know I'm making everybody pissed off. While I'm at it, SFOT.
Now be careful, doctor. I just did SFOT, so
I
I might get
understand. I
triggered. I
understand.
might get. Don't trigger me.
No, you have to
I'm
understand.
kidding. I'm kidding.
That's fine. Look, as you can see, I don't mind having people being upset at me. I learned that from Dr. Gimeno. Okay,
That's good.
I'm not saying I'm some grade or whatever. Okay, and I'm not, but I've been told that the life of a trailblazer is a lonely one.
Yeah.
Okay, I'm not saying I'm a trailblazer or anything like that. Dr. Gimeno was a trailblazer, but you can't be afraid of discussion, because I see that everyone is sort of talking about the same, just because someone says it and the next person reads it and says it, everyone starts saying it, it becomes fact, it becomes dogma. Okay, so let's talk about SFOT. I've done SFOT, by the way, on my son also. Okay, that's because those is, I was young and stupid. Okay,
I didn't know you were a periodontist.
I'm a surgeon.
Okay.
Okay,
Yeah.
when you SFOT for many patients, in my opinion, is a result of poor expansion pattern. Okay,
With Marpe.
with Marpe, when
You're
you
talking.
go ahead.
Please. I was I was going to say you're referring to when they do SFOT on the bottom so that they can match the bottom to the
No, I
top,
see SFOT on the top.
even after Marpe.
Yes.
I mean, that's what I did. I did it for a specific reason because my MSE was asymmetric, so I had a lot on the left, and you can still see on the right. I mean, I'm all forgive me, I'm all sorts of messed up, but I had an asymmetric expansion. I have a cant. Even 4 years later, I still have a cant, but I had very little expansion on the right side. I had a lot of expansion on the left side. So we did SFOT just to try to nudge my upper right quadrant out. And you can see the results of that, which are still incomplete and honestly a little bit underwhelming, in my opinion. So, you can see the upper right quadrant is still narrow compared to the
Yeah.
left, even after 23 expanding trays into my SFOT procedure. Just go ahead, doctor. I'm not a sensitive guy. You can just say it the way it is.
You know, I hate artificial stuff. I hate, in orthodontic surgery, I almost never use HA or all this other crap. Okay.
What's HA?
Hydroxyapatite.
Oh, to as an implant
Yeah,
almost.
like augmentation, and this is what you have for SFOT, right? I mean, or whatever,
Right.
coral, something out of a jar.
Sure.
Okay, because most of it, if not all, are going to resorb. Okay, to me, people get SFOT because when you look, you know how many patients that I've had that need a SFOT for the mandible?
0.
One. That's
Mm.
because I widened this patient after dome. And he was widened so much, and then basically we're trying to chase it. Okay, so he had to have SFOT. SFOT is a great operation. If your depends on your objective. If your objective is to speed up ortho,
Yes, I love that about it.
okay,
I mean, I was ripping
sure.
through trays every 3 days. It was amazing.
If your objective is to speed up ortho, fine.
Yeah.
By the way, orthodontic surgery speeds up ortho. It's the same impact. Okay.
Yep.
But
Yep.
when you have an unfavorable expansion and you're burning the buccal bone, right? You know that, right?
I do.
So you have to augment it, right? You have to fix it.
Yeah.
So,
Yeah.
and I've seen SARPE, same. Poor expansion pattern. That's why you need SFOT.
It's a cope to zhuzh up the bone that you burnt because of your, excess unnecessary orthodontic force on the teeth because of the bad expander.
Yeah, that is my opinion.
Okay.
I know a lot of people are going to disagree with me. Fine, I look under the hood every time that before I start my car.
No, you don't. Oh, because looking for a bomb. That's funny. That's funny. No. Dentists don't know how to rig up electronic devices. Come on.
You are right. I don't. Anyways, go ahead.
Okay, two more points about MSDO. How risky? Why aren't more orthodontists doing MSDO? They are using SFOT on the lower instead of MSDO. Is it because they're not surgeons? They're
We're not
afraid to
surgeons.
do it?
Look, whenever you do MSDO, look, obviously it depends on how the expansion occurs, right?
Mm-hmm.
If you got a lot of posterior molar tipping, okay, from the maxilla.
On the upper, yeah.
On top. You get a lot of molar tipping, and then you do ortho, then your maxilla is really wide, right? I showed you the post, that the teeth were like this. Now it's like that, okay? And then after ortho, it's like that, yes?
Mm-hmm.
So now you have almost developed Brody bite.
I've been there.
Okay? Then you say, okay, I'm going to do MSDO. Here's the mandible, right? Okay, that's the mandible, yes?
Yes.
This is the condyle, right? You know how MSDO works? It works
rotation.
This way, right?
Yeah.
You're going to get the most widening in the anterior and the least widening in the molars.
Correct.
I mean, what are you trying to correct? Okay, everything. Just because you could do an operation, it doesn't mean that you should. And what are you trying to achieve? Just like that, the Lefort. I mean, anybody can make. I mean, you can make that cut, but how's the movement going to be?
Yeah.
Sir. I hope, and people think that, look, when I treat patients, it's just not just let's do MMA. I'm going to show you the VSP, and there's a lot of thought process that goes into something. Does that make sense when you treat?
Yes.
I try. Okay, and if you're going to do a surgery, what are your objectives, and how's the surgery going to work? The MSDO is, by the way, you have a distractor in your mouth, and it's kind of it's uncomfortable. By the way, you have something that attached to the chin, right, under the chin, okay, or whatever on the symphysis, something that pokes through the gum. Yes,
Yes.
okay, that area gets kind of dirty, inflammation, and you take it out, you have scarring. I hate, it's messy in my
It's
opinion.
not elegant.
It's
It's
not
not
elegant.
elegant.
I want,
Yeah.
I hate operations that are not elegant.
Yes. Yes, I can see that. Is there any validity to the claim that the MSDO has a kind of airway improving effect by pulling taut the softer cogs in the airway?
You know, I believe that 20 years ago. So I think
I
yeah, go ahead.
I believed that 20 seconds ago until you.
You know, which tells, look, the answer is no. You can, and whatever movement that you're going to do is minuscule. Otherwise, you're going to develop a class 3, right? If you are really advancing it, because the only way to make it taut is to advance it.
Right. Right. That's a good
If
point.
you're going to advance it, you're going to develop class 3, right? Yeah, we're going to do MSC, we're going to widen it, and then we're going to do MSDO. Oh, we're going to have to do MMA. All right.
You are a tough cookie to crack, doctor.
Look, it's not that. It's just that, again, what are your objectives, and does it make sense? And show me the data, because it doesn't make any sense to me. By the way, I early on for 15, almost 15 years, I did a lot of genioglossus advancement, because that was the group. We did genioglossus, UPP, and all this stuff. And then after a while, I go, you know what? I'm not getting what I want. This results, like, I'm not happy with the results.
Yeah.
Okay. Conceptually, theoretically, it works. You're pulling the attachment genioglossus muscle forward. I mean, at least it makes sense. It kind of makes sense. Okay. But I don't get the clinical results. And the same group don't get, or at least I'm not happy with. Okay. It's not good enough. So I stopped
Yeah.
doing them.
You have a very high standard. You demand efficacy and elegance together.
Well, I don't know. I'm just a simple guy from, Southern, but it's, at the end of the day, I want to go home, feel like I've done my best and I've done a good job, and I could sleep well.
Yeah. Yeah. Well, I hear you, doctor. I think you've put the nail in that coffin for now. By the way, I would love to, and I'm just going to put this out there. Would you ever be willing to debate someone on my channel?
You know,
Like,
probably not.
like imagine a three-way panel discussion. You, Dr. Lipkin, Dr. Yusefian, Dr. Evans, uh, Dr. Wallin.
Probably not, because there's no reason to go over all the points, but yeah.
Because you don't want to hurt any feelings?
No, it's
Just
it's not worth my time.
Oh, it would be, doctor.
No,
Because think about
no,
would be
because
like the
you
great
know what?
debate.
But because what I try to do, Ron, is that I try to, because there've been a lot of questions, okay, and you know, I'm very free in my practice, meaning that I freely tell people what I believe they should know, that they need to know. I tell people my opinion. Um, I share my data, and um, I don't really care what people think of me, as you could tell, but show me your data. Show me your data.
Fine.
Okay. All these people that are doing all these things, well, if it's so good, look, anybody could put up 8 cases, 10 cases. Show me your sleep data. People that do all these MMAs, show me your data because I've seen them. That's all I can say.
Fair enough. Okay. This is going to be a fun one. Okay.
you may have to divide them into part 1, part 2, part 3.
Sure. Yeah. I actually was thinking when we hit the 2.5 hour mark, I thought, man, I'm going to have to cut this up into 2 different interviews. So
Any
I'm going to
other unanswered questions?
yeah. Yes, I'm gonna show you. Um, I'm gonna show you an appliance, and I'm gonna ask you: would you allow your son to proceed with this, or would you abort this and not even do it?
Is this a theoretical appliance or is it a
No, this is an appliance that's in someone's mouth right now, and this patient is wondering: should I turn this appliance or should I remove this appliance because it might do me more harm than good? So here's the appliance in his mouth. So this is a custom Marpe, and you can see it's fairly anteriorly placed. It's in front of, well, it's
Yeah, yeah. I mean, it's pretty typical. I've obviously there are variation of custom Marpe. Um, is what's the patient's age? What's the objective? What's the reason for the expansion? And was it just a device, or is it there are a lot of different sort of variables.
so I will tell you. So this is a male in his 30s, and um, he is doing this appliance because of persistent poor nasal breathing and sleep disordered breathing, sleep apnea. Um,
How severe?
very severe, very disabling. Primary feature of this young man's life is his sleep disordered breathing. Up to this point, he has been dancing around the issue, trying to essentially just survive. He's managed at this point to get himself engaged. He's going to be getting married soon. A big feature of his relationship with his fiance is that she understands how terrible his sleep disordered breathing is, and she's accepting of his journey to try to correct it. Um, and this young man's primary purpose right now is to cure his sleep disordered breathing.
There's no such thing as cure. Okay.
Fair,
I remember
fair.
people say, "Oh well, I saw someone, someone's friends or whatever that had ease, and they still need CPAP." I think you could sense that I'm never going to tell someone they're going to get off CPAP. They may very well be, but I'm not going to tell them. That's number one. Number two, there's no cure for sleep apnea. Everything that we do is kind of like curing high blood pressure. Okay, it's or curing aging. The goal is to improve.
Mm-hmm.
So if I assume that the patient has severe sleep apnea, AGI 30 or above, and what's his height and weight?
He's probably 5'9", 145. If I had to guess,
Okay.
he's a thin guy.
The probability of this device to even if it's successful in terms of expanding him, and we could debate on what successful expansion is. Even if this device is successful in expanding him, I will be very surprised that it's going to make a modest improvement in his sleep apnea.
Will it at least potentially improve his nasal breathing?
Depending on how the expansion.
It's in his mouth.
Yeah.
Is it worth turning the appliance and giving it a shot?
Look, sure, he could give a shot. I mean, that's fine. I mean, I think he should probably, as he expands, he should probably, watch his bite and get some CT scan interval to see how he's expanding, and then how his symptoms are improving or not.
So when you see one of these relatively anteriorly placed appliances, does it scream out to you, oh man, this is going to do more harm than good? Or does it scream out to you, underwhelming, but maybe still could help some?
It depending on what the practitioner told the patient.
Yeah.
If the practitioner told the patient that because I hear it, okay, that I was told that this is the treatment for my sleep apnea, that I don't need CPAP. Then I said, you're wasting your time.
Just regardless of what the practitioner told him, just in a vacuum, is there given his situation, and I can tell you visually, he's very narrow all around in his face, and that he's, definitely could just benefit from some nasal volume expansion. Do you think this is going to do more harm than good because of the potential for conical expansion, or not?
Conical expansion, again, it depends on the degree. Look, conical expansion is not like, I'm not saying that conical expansion is terrible, because conical expansion can still improve patients. But can you get better result? The answer is, in my opinion, is yes. Okay. But on a 30-some-year-old, it depends on, is it just a device alone?
No assist.
Good luck.
Okay. Worth a shot, but be careful.
I will be quite surprised if that he's able to open up his mid-palatal suture.
Mm-hmm. Mm-hmm. Okay. And your advice to him, if he decides to proceed, would just be keep an eye on the bite and have a scan done just to make sure that he's getting what he thinks he's getting in terms of expansion, rather than just tooth tipping and screw drag, etc.
Oh yeah, he's going to tip his teeth. It's just, I can guarantee you. Look,
Okay.
I don't want to sandbag whoever is doing this. Okay,
that's okay.
So it's but I think it's very unlikely, and that's the problem.
This is a European orthodontist, by the way, someone very far away.
Okay, and that's the problem, is that just because you could do an MSc. By the way, I think MSc is great in terms of that we're able to expand teenagers successfully without any sort of release. Okay, it has move it has advanced, but you're talking about a 30-some-year-old without any sort of release, just with this. Give me a break.
Okay.
And even if you're able to do it, it's what are you gonna? And you're gonna have your teeth tilted out significantly, and okay, maybe you're gonna widen your anterior. Even if you're able to split the suture, you're gonna widen it 1 millimeter. And I've seen people call it success.
Yeah.
Right. So
yeah.
By all means, use this for teenagers. That's more applicable. It's all about case selection, right? And that's what I see with the FME. Oh, geez, the company, you don't need it released. You just do this because we have 3D, we lock screws, this and that. Look, the anatomy doesn't change, right?
Yeah.
But sometimes, some patients, they have thicker bone. Okay, you could get better, and there are patients, you could get better engagement And, it could work, but it's uncommon.
Mm-hmm. Mm-hmm. All right, let's move on from that one, doctor. And thank you for opining. And that young man really wanted to hear your opinion because he's trying to make a decision. I don't know if what you said is going to influence him one way or the other, but
Oh, he'll give it a
it's
try. That's okay.
yeah, give it a try. Is that your bottom line?
I'm not going to tell him to do what. I gave my opinion. I don't think it's
Thank you.
going to be very. I don't think it's going to be very successful. If he's going to try, just keep a close eye on it.
Okay. Thank you, doctor. That's incredibly helpful. What do you think about when? So there's a team in Germany. There's a surgeon in Germany who that surgeon even calls her procedure ease. And MPS through the nose and releases the septum from the palate. PM sutures, uses chisels to cut. BW the incisors and from nostril and to nostril in front. Uses MSE instead of TPD after surgery. She doesn't use PIEZO. Prefers saws since they're guaranteed to cut through. Do you have any reaction to another surgeon calling their procedure ease? And I know that this gets back to what you said earlier about there's no replacing your experience and your different expertises, but what are your thoughts on that? Is it ease when someone else says it's ease, or is it only ease when you do it?
It's I don't have this is I don't have a propriety a claim on what I do. People could do it however they want to do it. Um, you know, it sounds pretty invasive to me. Okay, using saws and whatever this person is doing, it sounds pretty invasive to me. I don't want to, and the reason that I developed over the years because I don't want invasive surgery. I want patients to
Right.
walk out of here, come back smiling. How was it? Oh, it wasn't bad. I took,
Yeah.
all I did was some Advil, some Tylenol, and that's what I want. I don't,
Yeah.
anybody could do a big operation. I don't want to do a big operation.
Fair enough. Okay. Jaw surgery question. What are your thoughts on custom plates for jaw surgery versus the alternative?
All right.
What's this all about? This big stink about, oh, now everyone thinks that it's only modern jaw surgery if there's custom plates used. What are the cons of custom plates? Do you use custom plates? If not, why not? All that.
I think I've done more jaw surgery than vast majority of surgeons. And they've worked well in my hands. First of all, we're talking about MMAs, okay? Whether you do custom plates generally are thicker. Okay? In order to fabricate a custom plate, the plate has to be thicker. Number one. Number two, you could design a custom plate however you want, but the custom plates it's just more metal. Because the way it's made, it is not as strong as regular plates. Okay? And you could fabricate custom plate on the maxilla and the mandible. But you have to put in a certain jig to cut and to pre-design the cut on the bone, because that's how you make a cut here, you got to put the plate up, connect them. If you have the cut a little above, so you have to put in a jig to make sure you cut at the dotted line. Does that make sense?
It does.
Okay. especially on the mandible, you got to put in this contraption to make sure your cut follows the dotted line. Otherwise, the plate can only go in one place.
Right.
Okay.
If you screw up one part of it, you screw up the whole thing.
Right, because it has okay. So I don't like the added thickness because I don't like a bunch of metal in someone's mouth. Okay, and I don't like the, and you have to put in a jig. Okay, cut on the dotted line. This is how you have to cut because that's what you're letting the designer plate control your cut. Okay, well, whatever. Okay, and also when you do the MMA, are you going to do the upper jaw first, or are you going to do the lower jaw first? If you do the upper jaw first, you put in a custom plate, you design the cut perfect. Then you do then you do the lower jaw. You design the cut. You have to position the condyle, okay? And sometimes the position of condyle there could be a slight variability because the way you place a condyle on the VSP is what the company put. Okay, we're going to put the condyles right there. Okay, there could be a slight variability.
What's the VSP?
Visual surgical planning.
Okay.
You have to have, okay. So if all you do is the maxillary surgery, fine. But in mandibular in MMA, you're going to introduce a variable that is not perfectly controlled. Especially if you're going to do a fair amount of counterclockwise rotation, and you have to sort of position it a certain way. I don't like to do so. So that's the best way to do a custom plate. I like to do lower jaw surgery first, so that I don't have to position. So I just let the condyle find its natural position, and so basically it's the way that I like to do it. I don't think custom plates work as good. Okay, and in addition to the thickness, and there are so these reasons, I don't really think custom plate is anything to and you add another layer of you got to fit this in that it's it doesn't. I don't think it's all that, to me it's just a marketing thing. That is my opinion. Okay. Right. And I like to joke, people like to do all this stuff because they can't bend plates. Okay?
Right.
They can't bend plates. I've been bending plates for, I don't know, since residency, 30 plus years. I know how to bend plates. So.
Yeah. So it's something maybe that a younger surgeon might be drawn to as like an escape from developing the skills that older school surgeons had.
Yep.
Or
in
have.
my opinion. In my opinion.
So better to find a veteran surgeon, maybe in his 50s, 60s, who has the old school skills rather than the young surgeon that has the new tech that really, in reality, basically just allow him to kind of circumvent the process of developing the skills that are really needed to do jaw surgery, especially considering that custom plates come with these inherent disadvantages, especially around preserving TMJ health during surgery.
In my opinion.
And just to be clear, you're saying that the way you do double jaw surgery, MMA, is you first establish lower jaw and therefore TMJ health, and then you build the maxilla around the very carefully placed.
It's VSP, so I already designed it, and then you develop a splint, what we call intermediate splint, to sort of, you let the upper jaw is fixed, so you let the upper jaw guide your lower jaw, but then you position it. Then you sort of position a condyle, you fixate it, and then when you do the upper jaw, you're not pushing on the lower jaw. You're just letting a natural motion sort of set the placement of the plates with your new position on the upper jaw. If you ask most, in my opinion, I don't know. If you ask most experienced surgeons, I think they would tell you that they prefer to do mandible first.
Got it.
But surgery works differently in different hands. So,
Yeah.
you know, I've been doing it. Look, on rare occasions, splints don't fit as well. Okay, splints that you use to guide your occlusion into placement, they're not, they don't form fit perfectly. You have to. I mean, it's rare, but has happened to me. I think in my career 3 times or whatever. Okay, it's from the person that gives me the model. Okay, or whatever. So if you can't bend plates, if you you know if you do an operation that the surgery did not separate as designed, you're gonna have to improvise, right? Okay, just like you watch cooking shows.
I occasionally, yeah.
Okay, so
Alton Brown. I like Alton Brown.
if you're given a certain amount of ingredient, okay, and whatever the pork chop or whatever that you want to make partially burned, you can't make pork chop anymore. You have to make something out of pork, but not pork chop. You got to cut it. You got to, that's what surgery is about. It's not, even when you build a house, you have to, I don't know if you have to kind
Shit
of,
goes wrong.
something doesn't go as perfectly planned, right?
100%.
Okay, so you can't always depend on technology. Is great, VSP is great, there are a lot of things that are great, but if all you know is that, uh, I think there's a
You
problem.
you need to preserve the ability to manually override
Yeah,
with plate bending.
yeah.
Wow, that's a very, very deep critique of custom plate surgery, doctor. Very deep. Um, if you had to do an MMA surgery, who would you choose for your surgeon to do your MMA?
uh, that's a hypothetical question, and I'm not going to answer that, but I could tell you um, that I was thinking of doing MMA surgery on someone very close to me, and that you know, um, I asked an individual who was going to that I considered, having him do the surgery, but I don't think he's going to be practicing much longer. So I'm going to stop with that.
Okay, fair enough. I mean, I think that your sentiment reflects the sentiment of the community at large, which is that I don't think anyone has any idea who they want to do their surgery. I mean, we just all have the same 10 names that we keep circulating around as, oh, this is a good surgeon, that's a good surgeon. But I personally find it very hard
Sure,
to know.
it's look, you're gonna have there are a number of surgeons that are very good, I'm sure. Okay, just like there are a lot of chefs that are top notch, right? Same thing. But it depends on what you're looking for, and it depends on your rapport with patients, um, and that kind of stuff, and
Yeah,
depends on the experience, and you know that kind of stuff.
yeah, yeah. All right, doctor. One last question.
Great.
Um, um, what are you going to be asking for Christmas this year?
You know, I could honestly tell you that I'm an extremely fortunate individual. I love my job. I love my work. And I get all the satisfaction from taking care of patients and the feedback that I get from them. I'm not saying 100%, but vast majority of them. That's where I get my positive sort of reward. I don't really need anything, and I'm blessed with my family and all that, and that's that. And I know you already got your Christmas present, um, you know, not too long ago, and so be able to take care of patients is, I mean, is a privilege in terms of that. I think, look, there are a lot of things that we can do to help our patients because some patients are really, they're desperate, and and what I hope not to, what I don't like is that people think that taking care of patients is like a cookbook. Everyone gets the same thing. Everyone, it's not that. And we're nowadays influenced by industries, by companies, and telling patients, oh, I sometimes I see patients and I say, look, I've been doing this for a long time. I've done a lot. I think I know, and I try to tell them something that's a little different. I said, I think I know a little bit more about someone who has a fancy CT scan and took a weekend course.
Yeah.
So
Yeah. Yeah. Well, thank you for that, doctor. And you're right. I did get my Christmas gift last month in the form of my baby daughter. And I think the audience is getting their Christmas gift in the form of this amazing 3 hour and 45 minute coming up on 4 hour interview. I know they're going to be ecstatic, and I just want to thank you again for your time and for all that you've done for every patient you've ever treated and for the community at large. So thank you so much for joining me, doctor.
you're welcome. And congratulations again. Thank you.
Thank you. Until next time, doctor. Bye-bye.
Bye-bye.